Namaste and greetings. I, Dr. Sauravi Ghimire, Research and Communication Associate at IMPRI, Impact and Policy Research Institute, प्रभाव एवं नीति अनुसंधान संस्थान नई दिल्ली, extend my warmest welcome to you all to IMPRI #Web Policy Learning. We are gathered today for day 2 of an online immersive certificate training course on perspectives on gender through healthcare lens. This training course is organized by Center for Ethics, Yenepoya, deemed to be University, Mangalore, and IMPRI, Gender Impact Studies Center, or GISC, New Delhi. The patron of the program is Farhaad Yenepoya, Pro-Chancellor of Yenepoya, deemed to be University. Our course advisor is Professor Vibhuti Patel, visiting Distinguished Professor, IMPRI, New Delhi, former Professor, Advanced Center for Women's Studies, TIS, Mumbai. Our convenors are Professor Veena Vaswani, Director at the Center for Ethics, Yenepoya, deemed to be University, and Dr. Simi Mehta, CEO, IMPRI. We are very fortunate to have distinguished training experts, Professor Mala Ramanathan, Ms. Brunel D'Souza, Dr. Padma Bhate Diosthali, Ms. Sangeeta Rege, Dr. Ketki Ranade, Dr. Amar Jasani, Dr. Aparna Joshi, Ms. Renu Khanna, and Professor Anita Ghai. The distinguished expert resource persons have great experience gained in the field along with their expertise. I welcome all of you for this enlightening deliberation. As training experts for our second day training program, we have Ms. Brunel D'Souza, Dr. Ketki Ranade, and Amar Jasani. Before we start today's session, I would like to remind the housekeeping announcements once again. Please join the meeting on time. There will be Q&A session after each presentation. Share your questions on the Q&A box only and not on the chat box. Also, the questions must not be posted as an anonymous attendee. Please ensure that your questions are precise and refrain from making general comments in the questions to save time. And our course outline and reading materials by each expert has been shared over the Google Drive for your kind perusal. Please use a Google account to obtain access, as the file sizes are very high. Once again, I repeat, please use the Q&A box and not the chat box. Now I invite our course advisor, Professor Vibhuti Patel, to set the context for the second day and initiate the program with her opening remarks and invite our experts. We look forward to learning from the enriching deliberation. Thank you, and without any further ado, ma'am, the floor is yours.
For today's deliberation, I think it's important to know what transpired in the first session. So a recap of the sessions on 4th June. Now it began with the introduction by Professor Veena Vaswani, who expressed that despite overall progress in medical and healthcare institutions, there is a lack of thrust on gender sensitization, equity, gender responsiveness, and gender audit to make gender in healthcare more mainstream. Healthcare textbooks still propagate gender stereotypes, and graduate and postgraduate students are not sensitized to gender diversity. Hospital wards personnel find difficult themselves at a loss and as to how to handle transgender persons. Professor Mala Ramanathan, she was the first panelist who began with the WHO's definition of reproductive health and stated that while reproductive health approach was built on conceptualization of reproductive rights and justice, its acceptance in Indian context was within a framework of population growth and population control. She also gave a very important historical landmarks in terms of India accepting family planning policy, what had transpired during emergency, gross violation of human rights in a vertically imposed population control programs, hazardous contraceptives being tried on women, and women specifically organized against coercive use of contraception, and stress only on fertility control without respect for individual health and needs and rights of women. That was highlighted by her. And these global and local movements by women's organizations, women's rights movement, brought all of these players in the international conference in population and development in Cairo, which resulted in a paradigm shift from population control to reproductive control to reproductive rights. So, and she also was inundated with several questions about the assisted reproduction, and about which we are having a session today by Dr. Amarjit Sani. My presentation on gender implications of pandemic was about the differential impact of pandemic on different sections of society as their gendered vulnerability shaped by the intersections of inequalities in the labor market, intra-household power relations during stay at home, and lockdown orders in the matter concerning care, stress, domestic violence, that the reproductive health emergencies that the population women had to face, and the impact of shift in priorities of public health services regarding non-coronavirus patients, and the predicament of women who are in need of reproductive health care services such as contraception, anti and postnatal care, sanitation, menstrual hygiene, polio and neonatal vaccinations for the babies, differential impact of COVID-19 infection, and the resultant mortality and morbidity rates by gender, caste, ethnicity, class, and they were discussed. The third lecture in the on day one was by Dr. Padma Bhate Devastali and Sangeeta Rege. Dr. Padma's presentation was about she provided the sequential history of global and national level efforts at engendering medical education. She profiled efforts of Sehat in reaching out to medical colleges by fostering partnership, identifying opportunities, understanding perspectives of teachers, and review of textbooks from gender lens, and capacity building of select medical educators in gender analysis of health issues, identifying gender gaps in current curriculum, and developing gender content and testing the gender integrated modules in the classroom in the medical colleges. Sangeeta Rege took it further by actually sharing the experiences of testing gender integrated modules in several medical colleges, and how the Sehat team had used role play, quiz, debate, participatory approach for gender sensitization. She also shared the research findings of attitudinal changes among 628 medical students who were the respondents, that after attending the workshop, before attending the workshop and after attending the workshop, what kind of changes in their thinking, attitude, and perceptions came. And the results showed a strong association between number of lectures attended and the impact on gender attitude of students. She emphasized that gender as a social determinant of health cannot be relegated to a standalone lecture, but it needs to be mainstreamed in medical education to enhance understanding of gender concerns within medical and health issues, and gender can be integrated into medical teaching by training medical faculty, providing them with relevant material in the form of modules, presentations, and evidences. Now, the question in the Q&A session in day one, so many questions had a bearing on today's session. So first lecture by Dr. Ketki Ranade is on gender diversity, second one on the assisted reproduction, surrogacy, and the ethical concerns, and the third lecture by Professor Brunel D'Souza is about the gender and nutrition. So over to Dr. Veena Vaswani.
So We start the day 2 on a positive note, inviting Dr. Ketki Ranade to take the floor. And our participants have joined. Yeah, that's also a heartening thing to know. And thank you, ma'am, for accepting our invitation. And the floor is yours.
I would like to introduce Dr. Ketki Ranade. Dr. Ranade is the faculty at the Center for Health and Mental Health, School of Social Work, GISC, Mumbai. Dr. Ranade, the floor is yours.
Hi, good afternoon, everyone. Thank you very much, Professor Vibhuti, Professor Veena, and IMPRI. I mean, thank you for two things. One is, of course, thank you for inviting me for this session, but for having the session specifically dedicated to gender diversity in the context of health. So I was told that typically participants like to interact quite a lot and have several questions. So I will try to stick to about 30-35 minutes, max 40 minutes of presentation, and hopefully we'll have more time to address some questions that might come up. I'm just sort of recovering from COVID, and so still have a bad throat. I hope I am sort of clear and audible. Right. So let me start by telling you first what is it that I will cover in today's session, since we don't have sort of an extensive sort of time. We have one session. I do a course at this which is focused on LGBTQ health, mental health. So it's a 30-hour course. What I'm going to try and do here is just give you a very quick snapshot. So let me just tell you what is the order of my presentation, or what I have thought for today. So first is before we go into talking about gender diversity, I'm going to spend a little bit of time in talking about the gender norm. Yeah. And I'll say why that is so, that why is it important to talk about the norm before we go into what is diverse. Yeah. So that's the first bit that I will talk about. The other thing I'll do is I will refer to a few things that have happened in the legal domain and at the policy and sort of governmental level. So both in terms of what's been happening in the courts and what's been happening in terms of law passed by the Indian Parliament, and how that has an implication for particularly trans and LGBTQ health and mental health. So a couple of these court judgments and what we know right now about that. Finally, I will talk a little bit about, I'll give you an example of one lens through which to see mental health issues. What are some of the unique stressors, particularly with trans groups, but also, the broad spectrum of LGBTQ, and a little bit of a snapshot on what is being currently done. So there is a lot that's happening in India, several initiatives that are taking place. So I'm just going to run you through some of that. So yeah, these are the broad three things that I'm going to do. Let me start with the first bit, which is what is the gender norm and where does it come from? Now, the reason I feel that this is important to have this conversation, because otherwise, we talk about the normal and we talk about the norm, and then we talk about everything else, right? So that everything else continues to remain outside the norm. Yeah. And so in that sense, we do say diversity. And we do say diversity and difference, but very often we are actually replicating the old stuff about deviation and deviance and deviants. Yeah. So there is a sort of continued pathologization, medicalization, and othering that happens if we don't actually interrogate the norm. Yeah. So in the course that I do, I actually spend a good 7-8 hours looking at the norm and where does this norm come from. Yeah. Which we don't have much time for that, but I'm going to just begin briefly here. That we all know that we all as people, wherever it is that we are born, in the moment of birth, there is an identity that is ascribed to us, each one of us. And one of the first identities that is ascribed to us is that of sex, that this is a boy child or a girl child. Yeah. So the doctor or whoever, wherever it is that you're born, they look down there at your genitals and say boy, girl. And then begins, you are given a name, and then begins, what kind of clothes you are given, and, what kind of games you play, and what kind of prescriptions are there around, what education you should be doing, what hobbies you should be having, etc. Right? So that's the norm, right? All of us are assigned one of the two sexes, male sex or female sex, right? We are told, or rather, I would say this is medical assignment of sex to every infant, every human body, yeah, which is mostly based on external genitalia, right? Sometimes the external genitalia may be confusing, and so therefore the label of male or female may not be ascribed. But the point is that we make an effort to fit everybody, every human child into this either male or female, that is the sex, and then follows the binary of gender, that is man and woman. Okay, so everybody is given, there are only two possibilities, that is male or female, and there are only two possibilities of gender that come from, so the sex is equal to gender is what I've said here. So if it's a male body, male child, then there is man is the only gender possibility for this male body. And then with the two sexes, two gender model comes the one sexuality model. That is that these two are opposite to each other, and then they are attracted to each other, and thus is produced what is called as heterosexuality. And if we can take one step further, there is the two sex, two gender, one sexuality leads to one form of relationality, which is marriage. Yeah, in most of our sort of contexts, right? Now, where does this norm come from? Of course, we would say this is a social norm, but it is, what do we mean by social norm? It is also often naturalized. So we are made to believe that this is nature, this is scientific, this is how nature meant it to be. This is also universalized. The idea that this is how it is globally, everywhere. This is also ahistorical. It's always been like this. There are only two sexes, two genders, one sexuality, one relationality. That is what we would, we have sort of raised, brought up, education, everything tells us that this is how it is. And therefore, it's also normalized. So there is naturalization, universalization, and normalization. These are very complex processes. I'm just sort of telling you the, sort of what are some of these social processes. I'm just going to refer to this theorist, Gail Rubin, who talks about something called as thinking sex way back 1984, United States of America, very relevant to understand sex, gender, sexuality in today's context, 2022 as well. So one of the things that Rubin does is that Rubin tells us that this business of the norm, they use the term charm circle to say that, this thing about the two types of bodies leading to two types of genders, leading to one type of sexuality, leading to one type of relationality, is what is at the center of society. And Rubin uses the term charm circle to refer to this type of marriage, family, children, all of that comes with it. And Rubin says that it is actually a range of social institutions, from marriage and family, religion, caste and race, science and medicine, and state and law. So a range of these social institutions that uphold this charm circle. And of course, everything that lies outside of the charm circle, that is the possibilities that bodies may be of different types, which may have a combination of, how chromosomes, gonads, genitals, etc., all of that may work. So bodies could be diverse, genders could be diverse, sexuality could be diverse, and relationalities could be diverse. The minute these differences come up or these differences are there, these institutions are invested in somehow telling us that those differences are bad differences, and those differences need to be either cured, rehabilitated, changed, and brought back into the charm circle, or need to be excluded, or need to be something that we don't need to be, we need to be invisibilizing, erasing, not acknowledging, right? So I'm just doing like a 5-minute snapshot of how norms are created in society. I understand that this is a very thin argument I'm making right now, but for the sake of just getting us started to talk about diversity, I just thought that let's say this right in the beginning. And the reason I'm doing this is because if we do not begin the conversation by interrogating the norm, then what we are likely to do is continue to talk about these people as these people that exist outside of our social world, our lives, our families. So our families are full of norms. We are heterosexual people, we are cisgender people, we are nuclear family units or joint family units. We have children who are all normal, but then there are these people, right, who we need to serve, right? So there's this impulse as service providers, and I'm trained as a mental health care provider. I have been a mental health practitioner for more than 10 years. Very often we end up taking this stance of, let me do good for society, for others, right? And very often when we talk about inclusion, somehow what we mean is that the 2:2:1:1 is intact, right? That doesn't have to be interrogated, that doesn't have to be looked at. We will just include some more, right? So we will just get more people into our clinic and we will also provide them service. But my point is that actually if you start thinking that the 2:2:1:1 is something that has been told to us and has been reinforced time and again, and that need not be the only possibility for any of us, right? Then I think we sort of start to stir the pot. Inclusion doesn't become, just one plus one plus two, that kind of thing. The inclusion actually stirs everything. It stirs the binary idea of sex and gender and sexuality and everything else. And so that's the reason why I thought I'll spend the first maybe 7-8 minutes just saying that why is it important to interrogate the norm before we begin to talk about that which is not normative. If again, another thing that we see happening is that if we don't do it, if we don't start from asking questions about how is the normative created, very often we are likely to do this. What we do then is we define this other. So we say who's L and who's G and who's B and who's T and so on and so forth. We define, we classify, and we measure. And we have seen in public health, for example, as far as the HIV epidemic is concerned, this approach was very, very widely used, where what we did was we said that there was this growing alphabet soup is what I'm calling it. So I'll just give you an example that when HIV researchers were doing work on who was most at risk, one of the things they found out was that men were having sex with each other, but they were not calling themselves gay men. So they created a sexual behavior category called MSM, that is men who have sex with men. Yeah, because these people were married, they had wives, they had children. They were not saying I'm a gay man, right? But they were still people who were having sex with men and they were at risk of HIV, for example. So I'm just saying that this approach that has been there within public health, which is that of let's define a population, let's classify this population. So this is different from that. And then let's talk about who's at risk for what kind of health and mental health problems. Yeah, this is one kind of, if I may say, that it's one kind of a public health clinical approach that we have seen being used with communities that have been outside the charm circle and that have been illegal for a very long time, that have been pathologized for a very long time, that do not have other civil political rights that people inside the charm circle have, right? And if we don't start the conversation from the point of the charm circle, then what we are likely to do is some of this, where we will say, oh, LGBTQ people, QIA, etc., are more at risk for STDs, for HIV, for depression, for anxiety, for suicides, for substance abuse, and so on and so forth. Yeah. So, so while there is all this research that who's more vulnerable, who's more at risk, we'll come to that in a bit. But this was just something I wanted to start out by telling you. Now I'm going to jump quickly to, like I said, some legislations and some things that have happened in courts and in the parliament, which might be very important for us when we are looking at LGBTQ health or mental health. The first one that I'm going to refer to is what is called as the Transgender Persons Protection of Rights Act. This was a law that was passed in December 2019 by the Indian Parliament. 2014, the Supreme Court of India for the first time said that transgender citizens are equal citizens of this country. And interestingly, Supreme Court in this judgment, what is called as the Nalsa judgment, looked at the Constitution and said, nowhere in the Constitution, significant articles where we're looking at equality before law, we're looking at Article 21, which is right to life, etc. Everywhere in the Constitution, the term used is person or citizen. So Supreme Court says that this is not about men and women, and transgender people should definitely have as rights as citizens. So that's the court in 2014, and in 2019 you have this law. Now this law, I think specifically as healthcare providers, a couple of things that we should sort of acquaint ourselves with. One is that under this law, anybody can go and file an affidavit, go to the district magistrate. Now we have what is called as the transgender portal. It's a national portal where you can make an application saying that I was born or I was assigned this gender, this name at birth. I don't identify with this gender, and I would like to be known by this name or this gender, etc., etc. So, as a transgender person, I can actually make an application and change my birth assigned gender. So, if I have F female on my birth certificate, that can be changed. But since if I have female on my birth certificate, but I want to change this to male, and I'm saying that I have always felt like I'm a man caught in the wrong body. I'm a trans man. and I need to undergo social, legal, medical transition. Yeah. So I basically want to be called by this name. I want to wear these kinds of clothes. I want to be addressed by these pronouns. I want to be able to get hormonal treatments, surgical treatments, and so on, to be able to live as a man, right? Then we have what is called as Section 7 in the Transgender Persons Protection of Rights Act, where you have the role of a medical officer who will certify that I have undergone some kind of medical intervention, some kind of medical procedure at your setup, at your clinic, or at your hospital. And it's with your certification that I'll be able to apply for male or female gender identity. If I'm applying for a transgender identity, that I can do through self-declaration on a national portal. But if I need to change my identity to the gender that is considered opposite to the gender that I was born in, right? Because we are still operating in the two gender model, right? Then there is a major, very important certifying role in that sense for the medical superintendent. The other thing is Section 15 of the law, which looks at a whole range of healthcare rights. Of course, there's a lot of focus on sex reassignment surgeries, what we today call gender affirmative therapies. And there is focus on separate surveillance for HIV and so on. There is alongside that some interesting things here. One is it looks at the law says we need to review existing medical curriculum and we need to encourage research on specific health issues that trans people may face. We need to facilitate access in healthcare institutions, which means all those questions about gender binariness of our institutions, right? You have the male ward and the female ward, and then you have the male uniform and the female uniform, and then you have the male toilet and the female toilet, and so on. So if for example, my birth certificate says female, and I come to you for some kind of maybe for my gender affirmative therapy or for something else, or for COVID, for example, because my certificate says female, irrespective of how I identify, you'll probably put me into the women's ward and will ask me to wear the women's uniform, the gown, and so on and so forth, right? So all of these kinds of questions are something that the law is trying to address. These are very, very specific issues around health that it is raising. Now I'm going to take you to two other interesting judgments. This is Madras High Court Justice Anand Venkatesh. Interestingly, Anand Venkatesh was listening to a case of two women who had run away from their home, and parents had, both for adults, parents said that one had kidnapped the other, right? And Anand Venkatesh, one of the first things he said is, so the women said that they're in love with each other and they want to run away from their parental home. So Justice Venkatesh said that he was sort of famously said this thing that my upbringing has treated homosexuality as an anathema, and I myself need to overcome my prejudice. And so he went in for counseling, after which he gave some very interesting High Court order. And I'm only going to refer to one part of it, where he said that the National Medical Commission needs to review curriculum, particularly, so the advisory said that in areas like forensic medicine, toxicology, psychiatry, etc., certain unscientific and derogatory remarks about LGBTQIA community are present. And so the National Medical Commission in October, so Justice Venkatesh order is June 21, October 21, the NMC basically issued sort of an advisory saying that these kinds of references in medical textbooks need to be taken out. After that, they formulated an expert committee to look at specifically two, psychiatry and forensic medicine, but two streams that were looked at, particularly for the competency-based medical education, the MBBS curriculum that is there. And this expert committee, I think some of us were consulted by this committee, and they have put in their report in January this year. So so basically this expert committee, what they're doing is they've modified competencies for the MBBS curriculum, and that's just something that might be important, relevant for us. I can send across, you can also find this on Google, Justice Anand Venkatesh's order. The expert committee report, parts of this you will find in the order itself, right? The other thing that Justice Venkatesh did was he talked about banning conversion therapies. That is attempts that are made to cure homosexual people, transgender people, basically anybody who's outside the charm circle. So he sort of for the first time said that we need to ban conversion treatments. The other context to this, I'm just going to quickly tell you about, is that again, 21 last year, in May 2021, you had this young student, Anjana Harish from Kerala, who died by suicide. And just before her death, she had put out a Facebook live video saying that her parents had put her through forced conversion treatment after they found out about her bisexuality. And she had been sort of forced incarcerated and so on. And it's in that context that she wants to end her life. What Anjana Harish's death did was that, as tragic as it was, but for the first time in that sense, a whole lot of health associations came forward and gave out statements condemning conversion treatments and said that, so the Indian Psychiatric Society for a long time, I mean, they had said this earlier as well, but several other clinical psychology associations, psychiatric social work association, a whole bunch of these associations came forward and said that we cannot try to, it's actually conversion treatments in the form of human rights abuse. And that discourse sort of entered within and this is very, very new. I'm talking about last year. So it's not even a year, not even a sort of anniversary to Anjana Harish's death. After Anjana Harish's death, there is a petition in Kerala High Court also seeking ban on conversion treatments. And in the meantime, Justice Anand Venkatesh of Madras High Court gave this order. I'm just going to jump from this again to another, referring to the Madurai bench, again, in that sense, technically under the Madras High Court. And this is Justice Swaminathan, who said something about intersex infants and children. Which is again something to be noted. This happened in 2019. And what does the Tamil Nadu government talk about when it comes to intersex infants? If you remember in the beginning, I said that normative sex is basically two possibilities, male and female. And within the medical discourse, there has been a very long history of anybody who doesn't fit into the male and female in terms of the sex characteristics. So for a long time in the medical discourse, such people were referred to as having disorders of sex development, DSD, that later on changed to differences of sex development. And now increasingly there is an understanding of what is called as intersex variations, to refer to the fact that sex characteristics might actually also be diverse and different. And Madras High Court, the Madurai bench gave this order in 2019, which is basically, they said that we need to ban what are called as medically unnecessary intersex surgeries, which is basically when a child is born, if a child is born with intersex variations, even on infants, surgeries that are done to somehow fit them into, the male or female sort of sex options. So this government order said that sex normalizing procedures need to be banned, surgeries on intersex infants, unless it is indicated medically. So, unless there is a necessity. For example, a child, is not able to, the passage for, being able to pass urine is obstructed, or, so where there is a life-threatening situation or medical indication. Not to fit the child somehow into this sex or that sex. And then the other thing that the order has done is that they've talked about a committee comprising of pediatric surgeon, neurologist, endocrinologist, social worker, intersex activist, and so on, such that if a surgery has to be performed, which is a sex reassignment surgery on a intersex minor or an infant, then this committee needs to look into it and say whether this is socially indicated or medically indicated. Like the parents might be distressed, or the doctor may believe that intersex infants is some sort of an abnormality, but is this medically required? So this is, I just wanted to share up till this point, just to tell you what is happening in at the level of courts and at the level of laws that are being passed, and where are we as mental health providers sort of implicated, where is it that we need to educate ourselves and think about. The next bit, and I don't know how I'm doing with time, I'm just going to quickly check. Okay, I think another 5-10 minutes and I will stop. So the next bit is, what do we know about health and mental health issues of LGBTQI persons? And I'm going to draw your attention to 2 readings, one of which has been given to you. Both of these are reviews. So the first one is a 10-year review from 2009 to 2019. 2009, first time Delhi High Court decriminalized homosexuality. So these authors have actually looked at 10 years, between 9 to 19, health literature and mental health literature. What is it saying about LGBTQI issues? And the other one is about barriers faced by transgender persons in accessing health services. which is something that I have shared with you. So this is something you can take a look at. I am not really going to go into specifics of health conditions and so on. I'm just going to actually quickly take you over. If we look at the overall health discourse on LGBTQI issues, in some ways, in the early 90s, we began these conversations in the context of HIV, where we talked about gay men and men who have sex with men as being at sexual risk. So in many ways, there was, groups that were at this point of time, of course, they were illegal. So we had Section 377 very much on the Indian statute books. So criminals in that sense, seen as abnormal and pathological, and then additionally also seen as carrying sexual risk. In late 90s, in addition to men who have sex with men and gay men, also trans women, and particularly trans women who are sex workers, were added in addition to female sex workers. So that is cisgender women who are sex workers, and then injectable drug users. All of these, of course, all of these high-risk groups were illegal. Right? And so those conversations began to happen within the HIV public health context to talk about risk population to what is then called vulnerable population, as people who are structurally excluded, discriminated against in the context of stigma, discrimination, police brutality, violence. Right? So you see, over 2 to 3 decades, you see a shift towards a social determinants, structural determinants approach to try and understand health concerns of LGBT persons. Syndemics approach, which is basically trying to look at multiple disadvantages coming together. So some of the work by Dr. Venkatesh Chakrapani and others who've looked at, particularly in the context of trans women who are also sex workers. So they've looked at the sort of relationship between poverty, facing violence and victimization, use of substances and depressions, all of these sort of forming syndemic conditions coming together, and how do we understand therefore health risk and vulnerability in this context. Some of the work I have been doing, which is what is called as the affirmative approach to mental health of LGBTQI persons, is basically validating of identities that lie outside the charm circle, understanding rights and linking the experiences of structural marginalization and discrimination, and linking that with health, experience of well-being, experience of mental health and so on. Yeah. So I'm just going to, before I stop, I'm just going to take you through 2 more ideas. Okay, I can see there's already some questions. I will take it in the end. So one is minority stress model. I think it's an interesting model to understand LGBT health and mental health issues. Something that was given by Ilan Meyer, who's a public health professional at University of Columbia. So minority stress is basically stress caused by stigma, prejudice, discrimination. Minority stress is defined as something that is unique. It's a unique stress when I get misgendered, for example. Yeah. When someone refuses to see me in the gender that I am, because they insist that the gender that was given to me at birth is something I should get along with. Yeah. It's unique because everybody is expected to get married at a certain age. Everybody is expected to have children and families, right? But someone who doesn't fit into that form of being, so in that sense, it's sort of unique to LGBTQ persons. It's chronic. It's not something that comes and goes. It's not like at the age of 40, even at the age of 40, when you're first, you're changing a job, for example, you still have to take that call on whether I should come out as a queer person in this workplace or not. So in that sense, it's chronic. It's something that will stay with you for a very long time, and it's obviously socially, culturally embedded. It's socially based. So I think these are some, and it's also to say that it's additive. So when I do work, I have written about growing up gay in urban India. One of the things I talk about there is to say that, everybody, so let's say adolescent of any kind, goes through, many issues, psychological issues, social issues. Forming identity, figuring out a whole lot of things. But sexual minorities, for example, go through that additive stress. So they go through what others go through, and then more. The other bit in the minority stress model is to also compare sexual gender minorities with other minority groups. Yeah, so racial minorities, religious minorities, and so on. And one of the distinctive feature again here is that LGBTQ folks tend to be minority even within their own family. because they're often born and brought up within heterosexual cisgender households, and so what that means is that this is a type of minority identity where you have to look for your own identity, as compared to, if I was someone who is in a religious minority community, I'm in that sense at birth given this identity. It's elders in my family that tell me that what does this mean. So a minority identity is instilled, and therefore in some ways the community is invested in helping me cope. So it's like minority coping is also something that is that's something I may have access to in that sense. Whereas here we are saying minority owned family means you have to look for your community and so on. Finally, I think before I stop, okay, this is do with unique life stressors. I think I'm not going to go into details of this. Some of it I have mentioned already, but some of the stressors related to, you'll see this also in the articles, the barriers to healthcare access, the kind of issues that people face as unique life stressors in healthcare settings. And that's something I'm not going to go into too many details. These are some initiatives that are currently happening in India. Those of us here who are interested in trans healthcare, we must go and look up. The Association for Transgender Health India has a website, and they've come up with what are called as standards of care for persons with gender incongruence. So gender incongruence is a terminology that is also used to refer to transgender people. NIMHANS has come up with a manual on transgender mental health. There is other kinds of work that is happening on. So I think you heard yesterday on gender mainstreaming in medical education. There is some effort there to include LGBT questions as well. But some of these other efforts which are specifically focused on, looking at medical education, looking at mental health education, which is what I have done, this queer affirmative counseling practice resource book for mental health practitioners. It's available online. You can just look up this as well. So yeah, so these are some of the initiatives that are there in India currently. How are we doing in terms of time? I am on this full screen mode. So, okay, right. So I think I should stop now because we have about 18 minutes for questions. Yeah, so I'll stop here.
Thank you, Dr. Ketki, for the enlightening presentation and touching up on key issues related to gender diversity. Now, I would like to call upon Professor Vaswani to give some insights on the presentation before we take up the questions for Dr. Ketki. So, ma'am, please share some few words.
Yeah, sure. So today we touched upon very important aspects of gender, starting with normativity, what we consider gender normative, and especially when we have a restrictive way of normativeness, then how the otherness will discriminate and get a person out of the system. Very beautifully, Dr. Ketki Ranade has unfolded her presentation, how pathologization, how medicalization, and ultimately it just leads to getting one particular community of transgender LGBTQ out of it. You may call them by any names, but then it doesn't just matter as long as you don't give the recognition as they are one of us. So she went on even to describe, especially when they talk in relation to post pandemic, she also brought in the positive changes that are happening, and then and according to the NMC guidelines also, Dr. Ranade, it's very heartening because we do teach it, but many times I do wonder how many of our teachers are into it, how many of them accept to teach, or how many of them think that it is something that is, they're not immersive about it, but rather it is given so you have to follow it. That's all. So this is where I thought this is a very important thing that you brought out, and we hope that participants are very much into the understanding mode of how best we can internalize in the healthcare program. And very pertinently about the conversion therapy, actually it all started in Johns Hopkins with the very first case of the twin study, where one was made to be a boy and the other to be a girl, and they were groomed in a way which never worked out. It had a disastrous consequences, but subsequently there has been n number of papers, and somewhere it is the science that has done injustice to humanity. that today we think by converting we can make them normal, and normal is again according to our own lens. So madam brought this up very well. And so overall I think we need to look at, when we are accepting the present court judgments, including about Justice Venkatesh, Judge Venkatesh, what he said, that unless we open our minds to looking at others as a part of us, there is nothing short of it. Everyone is a part of us. We could have been in that position. We are in this position. It is just a change in position, does not make anybody different than the others. So that was very nicely brought out, ma'am. Thank you for that.
Thank you, Professor Baswami. Now we move on to some question which is already there on the chat box. I would read out the questions for you, Dr. Kitki. The first question is by...
I can actually read them and respond if that's okay. We can save time.
Okay.
Yeah.
All right. All right.
I'm reading already. Yeah. Okay. So the first one, I think, which was about sex changing procedures and whether practicing surgeons are aware of this committee. So I just wanted to clarify. So there are two things that I referred to here. One was about medically unnecessary procedures to fit an intersex infant into one or the other sex. Yeah. So that is also being referred to as sex changing procedure. The other is where transgender persons, so that is somebody who has been assigned gender male at birth or gender female at birth, those who don't get along with the gender that was assigned to them at birth. So for example, I may have been assigned gender female at birth, but as I was growing up, I said, I just don't feel like a woman. I feel like a man. I feel like a man who's caught in the wrong body. And then I may need to make changes to my body to fit my sense of gender. So this is what is called as SRS, or what is called as gender affirmative therapies. And that's something that the trans law also talks about, that we should be providing these services. There are several policies of some states, at least I know Kerala, Tamil Nadu, some of these who have talked about providing these in medical colleges, in state medical hospitals attached to medical colleges, and so providing them free of charge or at minimal cost and so on. So just to respond to that question about whether practicing surgeons are aware, vis-a-vis intersex surgeries, we do know that a lot of intersex surgeries still do happen, and they happen under sometimes the practitioners believing that what is the future for a child who is not male or female. And many times they happen also because parents pressurize that they think they would like some intervention to happen on the child. There is, like I mentioned, there is an organization that is looking at intersex infant or intersex persons' rights. But yes, to respond to your question, are people aware? They may or may not be aware. This is only one court's judgment. We need to do a great deal. And I think also research on intersex persons is very, very poor. What are some of the health issues, mental health issues is something we know very little about. So we need to find out more. The next one is about syndemics approach, where it's originated. Actually, one thing I would suggest is, I think I mentioned, do take a look at work done by Dr. Venkatesh Chakrapani, who's a public health researcher, and he's done some interesting work on syndemics vis-a-vis LGBTQ persons. So you can just look up on Google Scholar, you'll find writing by him. When we are doing gender mainstreaming of programs, we assume gender norms to be universal. This may be a problem. Absolutely, yes. I think in many ways, when we talk about gender, we are talking about women. And that's something that has begun to change, which I'm really glad, because when we say gender mainstreaming also, sometimes what we mean is we are going to raise issues of women's health or women's mental health and try and sort of look at how women are disproportionately affected or disproportionately because of social norms and conditions. But yes, sometimes we do assume gender norms to be universal, and yeah, that's a problem. Yeah. Okay. Language matters, absolutely. One of the things I must say is that I have started seeing among my students that people do this regularly. Along with their name, they put down the pronouns that they use. So if you're a cisgender person, and you're a someone assigned female at birth, then you're using pronouns she, her. So people say she, her. Whereas there would be people who use they, them, and other kinds of pronouns. So to refer to gender diversity. So absolutely, language matters. Language tends to perpetuate inequalities. Don't you think words like homophobic, transphobic need to be replaced? Yes, with respectful terms like homo negative, trans negative. Yes, I think respectful. I think they are more accurate descriptions. So homo negative, prejudice, or trans negative, trans prejudice is a more accurate description than phobic. Thanks for raising that, Nandini, because we understand phobia is a mental disorder, right? And I mean, if I have phobia, I would want you as healthcare providers to provide me help and care and support and all of that. Whereas when we are talking about something like prejudice, I am prejudiced because I can. I simply am someone who's in a position of privilege and I can choose to be prejudiced against minority group. So phobia and prejudice are not the same thing. So it's best to not use homophobia and transphobia, but if we can use trans negativity or trans prejudice, that would be good. Being a minority is itself stressful, is what Dr. Shakun is saying. How can we deal in mundane life to cope with? Yes. One of the things I do is quickly, just to give you an example, because we have some time, this thing about minority stress, right? In my classes or in the sessions that I do, we have a whole lot of training methodologies where we do simulation exercises. So one of the things I do with when I'm working with mental health professionals, particularly heterosexual women or heterosexual people or cisgender people, what I will do is, we have one exercise which is called as 1 day in the closet. Okay, where we basically tell people that you spend this whole day, in the whole day you will not make any reference to your sexuality or your relationship status. Okay. And just note down what happens. Which are the conversations that you must censor? Because you cannot make any reference to husband, wife, children, in-laws. You can't say a simple thing like, I had to get up early today because my child had a picnic and I had to, cook something. So you can't say things like that. So which means you have to censor so much in your everyday life if you were to actually not make any reference to your sexuality. Similarly, we do an exercise where we say that you are parents and a child is being given to you and you have to look after this child for the next 10 days, for example. The genitals of the child are covered. Okay, so we're basically saying that you don't know the sex of this child, right? Now, how will you relate to this child? And just a simulation exercise that in terms of what is a name, pronoun you will use, what kind of clothes will the child wear, how will the child address you? Because when you are seen as male and female, or man and woman, or dad and mom and whatever, the child will then want to know what their gender is, right? So so it's just, these are various simulation exercises to get those of us who may be in positions where we are cisgender, that is a gender that was given to us, works for us. So if I was called a woman at birth, I actually am a woman, I live as a woman, I don't have any problem, that's cisgender. Heterosexual, yeah. So these are some of the ways in which we do simulation exercises to help people have empathy for what minority stress can mean. Okay, are there more questions? I think I have covered the questions.
With that, I would like to thank Dr. Katie once again for taking all the questions and enriching this session. Before we move on to the next session, I would like to invite Professor Vibhuti Patel to add some comments and conclude this session. Over to you, ma'am.
Box that it was really a great learning experience for all of us. The conceptual clarity with which she spoke gave all the deconstructed all the landmark judgments, government rulings, and changing the last question. I think still Ketki has a scope to answer by Sagar, that how can we change the mindset of people and people's attitude? How should be the roadmap of going ahead, pathway to change them?
Yeah, sorry, I think the question and answer has been closed, but Professor Vibhuti just sort of paraphrased that question. I think ways forward at multiple levels. I mean, I think because this is a group of people here who are healthcare providers, mental health care providers, I think paying attention to curriculum, what we are teaching in class, how we are, doing more empathy building exercises, lived realities. I have really noticed that, I've done panels where you have young people, queer, trans, gay, intersex persons who come in and actually speak to professionals, and that makes a lot of difference. I use a lot of films when I'm doing some of these trainings. So I think that is very, very helpful. And the other thing that I was saying right in the beginning, that inclusion actually should mean that we should stir everything. It should not be +1. Huh? So what I'm saying is that if I'm doing, it's not about adding one chapter on LGBT health and mental health. But it's actually like, for example, if I'm doing something on gender mainstreaming in medical education, where I'm talking about, let's say, sexual violence, and as doctors, how do we address, when we have someone who's having faced sexual violence? I must think that this is not just about cis women. This could be a trans woman who has faced sexual assault. So how and what is it that I'm going to do in my clinic, right? When I'm talking about reproductive health, for example, when I'm talking about menstruation, for example, this could be a trans man who's not yet had, has not yet started on hormones and has not yet had medical transition. So he's socially appears as a masculine person, but might be having menstruation, right? So I'm saying that we'll have to really, the point is to open the two sex, two gender, one sexuality model, and start sort of looking at lives that are there outside of this. So yeah, so I think if I can just say that.
Yeah, brilliant. That's great.
Thank you, Dr. Ketki and Vibhuti ma'am as well. If there is any other question from the panelists, we can take it for now. And before we move on to the concluding remarks by Dr. Ketki. Dina ma'am, if you have any comments to add?
Yeah, I was just talking about one comment about the services offered by the healthcare agencies state-wise. We are not very clear about it even today, because we have a community with a transgender when we meet every month, and they go to places like which are cheaper, and cheaper does not necessarily mean it's hygienic and done in a scientific way, but cheaper because it costs 15 to 25,000, whereas hospitals charge 1 lakh to 1.5. So that is how I think the state should make it a very transparent policy. And unless they really mean the welfare of transgender people, then otherwise we would be losing a lot of people to infection and something that they can't come out to. So.
There is one more question from Dr. Alka Dupkar in question box.
Yeah, I think again connected with what Professor Veena was saying just now, what Alka is also mentioning here is there are schemes, some of which we don't know about, some schemes we are not clear about what's happening, because all this is, like I said, after 2019 December, large part of it is the pandemic period. So how much have we been able to do IEC, how much have we been able to reach communities, all those are questions. But also, Professor Veena, what you said, there is some writing on post-op care being really, really poor, and what that has meant for, so basically surgeries being botched up. Particularly, and it's actually, I mean, I feel that with the way the curriculum is, the way the training is, very often well-meaning doctors are sometimes experimenting or sometimes trying out things as well, and don't have reference points. So I think it's really a cascading effect of some of that. What Alka Dupkar is mentioning is about the SMILE guidelines. I would say yes, that the Ministry of Social Justice and Empowerment and National Institute of Social Defense are two places central with the central government from where a lot of schemes are being rolled out, SMILE being one of them, which also has health related interventions as well as education, scholarship, etc. for trans people. So yes, so Alka, just to respond to you, I think people like you who are doing so much wonderful journalism and putting out some of this information, I think that's really the way forward. Sometimes announcements are made, and I agree with you that not all of those reach people. Sometimes they don't really, there is a scheme mentioned, but there is no budget there. And so I think what some of you guys are doing, and I think as journalists also, following up on some of these things is, I think, the way forward. Thank you.
Thank you, Dr. Ketki, and please end the session with your concluding remarks.
Okay, just to say thank you and wonderful timekeeping, I must say, to everyone. 3:31 exactly. Thanks a lot. I really enjoyed being here, and thanks for the questions, and Professor Vibhuti, Professor Veena, for your remarks as well. Thank you.
Earlier, we had kept 15 minutes buffer. Now we have scrapped it because there are such a motivated participants. So, yeah, continue.
So we move on to the next session. Our distinguished expert for our second session is Dr. Amar Jasani. Dr. Amar Jasani is independent researcher and teacher of bioethics and public health, and also the editor of Indian Journal of Medical Science, Medical Ethics. We would like to welcome you, sir, and please take over the session.
Can you stop sharing so that I can share my screen? Okay. Is it visible?
Yes, perfect.
Okay, great. Well, first of all, thanks for having me here. And to connect to what Ketki has been talking about just now, we go into an area which is equally problematic, as far as mindset of the society is concerned, as well as its moral norms are concerned, and that is assisted reproduction. That is where equally bad controversies are there. Although the issue of diversity in gender, the LGBTQI plus people, and the kind of problems they face is much higher and much different from those who are infertile. I think they still do have a large amount of problems which are created by the social norms. Anyway, this is the journal that I thought I will introduce you to. It is Indian Journal of Medical Ethics, being published for last 30 years. It is a multidisciplinary peer-reviewed index journal. And of course, you are welcome to publish in this journal, because we need not be a doctor to do that. What we need to do is have more reflection on the social and healthcare ethical issues. So this is what I'm going to do. I'm going to cover very quickly several issues. Look at the issue of reproductive rights in relation to the assisted reproduction. Look at infertility as a neglected issue. And what are the issues which are coming up, gender and ethical issue, from the context, that is culture, religion, and morality, and the discrimination. Also, safety issue, also talk about little bit about surrogacy work and the exploitation. And lastly, the new laws that the government of India has brought in. Well, all of you know that I think Mala must have talked about reproductive rights, or reproductive health and rights. And the dominant discourse in our country has been, to emphasize on the family planning, not to have child, not to have too many children, or have a policy which is anti-natalist. And however, the real meaning and understanding of the reproductive rights is that it includes not just not to have child, but also to have a child. So in the population control framework, anything that is related to infertility, people not having children, yes, completely ignore. Now, that does not mean that those which are the countries which are pro-natalist, where the population growth is very, very low or even negative, and they give incentive to have children, they are very good in providing assisted reproduction. They have a different kind of problem. They are more related to the religion, culture, and other factors. And because of this, you'll find that in most of the countries, the public investment in reproductive health or assisted reproduction is very, very low. So the provision, that is a public provision of the support for assisted reproduction is minimum. And there is, because of that, there is a lot of commercialization and the exploitative use of the assisted reproductive technology. This is a paper which provides you comparative study of lower and middle income countries and high income countries. And you'll find that there is no clear-cut trend here. It very much depends upon the context, political context of the country in terms of provision for the for services for the infertility. Infertility is a very significant issue, a medical issue, and its prevalence is anything up to 10% or even more. And there are wide range of causes of infertility, both in men and women. Almost 1 out of 5 are not explainable. We don't have exact understanding of why it is being caused, but they are there, and they need intervention. The old treatment mode, when I studied medicine, when I was told about, was well, to look at certain drugs, intrauterine insemination, tubal surgery, if tubal block is there, and that kind of stuff. And there were a lot of very, very primitive tests that we used to carry out in order to diagnose it. However, from 1980s onward, we started having technology which started using on a regular basis in vitro fertilization. In the laboratory, we do the fertilization of egg and then do the embryo transfer in the woman's womb. So there are a huge range of technologies that come up there, or procedures that come up. Ovary stimulation, how to retrieve eggs, how many eggs to be retrieved from woman's body. This sperm retrievation, from the man, and even from the cadaver, when a person dies and there is a requirement. Then how to transfer this this embryo into woman's womb, and that kind. So there is a wide range of procedures, and each procedure has its own problem. And then in addition to that is that there is use of surrogate, where a woman is not able to bear the child, and so another woman is hired in order to do it. So this is these are the a wide range of new technologies that is coming up. Now let us look at the context, that why infertility, where the public investment is low, becomes a major demand factor in the society. So that is one is that how women are looked at, and that is a very, very moral question, that a woman is considered to be incomplete, not worth to be part of certain cultural and religious norms if she doesn't have pregnancy and childbirth. And the man requires a progeny of some kind. If that is not there, he is considered to be less masculine or not masculine enough. So health seeking for the infertility is rooted into that pressure coming. Even those couples who do not want to have a child, they come under massive pressure to prove that the woman is fertile, can have a child. And in addition to that, all of you know about the son preference in our society. So there is a demand for having male child. So these demands are very much socially constructed, and it depends upon what is the need that people feel about having their own child. And given this, the real pressure that coming from below, it always becomes very, very difficult the extent to which those who are seeking this care are going with free and voluntary choice. I think we face this problem when in 1980s, the amniocentesis and sex selection debate took place, and where a woman goes there and says that, yeah, I want to have sex determination. And but at the same time, you find that she is there because of massive pressure that is coming from below. So you have on one hand the issue of agency of the woman, on the other hand a milieu which forces the woman to take the behave in certain manner. The another area of major debate in the social context is about the embryo. As I said, that there is a ovum taken out, and then it is fertilized. There is an embryo there. Embryo is in the petri dish because it is done in the laboratory and then transferred to the woman's womb. So how does one look at the embryo? There are a lot of cultural, religious norms there. Is the embryo is a person? Because you are manipulating all these things with the embryo. Then if the embryo is treated as person, then said no, you can't do anything with that. Right? That's how many religious positions will even talk about not having contraception, not having abortion, simply because embryo is a person, and doing any kind of manipulation that may lead to unnatural processes or a possibility of harm to that embryo, they are not considered to be right. But there are other different positions. They say that, well, embryo is nothing but a tissue. You'll find many rationalists, scientists will saying that, well, it is nothing. It's just like any other tissue, and it can be traded, it can be destroyed, it can be researched upon. Another people will say that yes, it is unique category, but not as good as person. Don't give full rights of the person. And so, in a regulated manner, one can do the manipulation and the research on it. One more position is that yes, it is a human, like first position, it is a person, but it does not have rights of the human. Right. Particularly, the number 3 is a very important in our country, because in our country we do allow certain kind of research, and at the same time we also have a strong regulation in place now about how they should be. And there are religious positions. Christianity has one, Judaism has another, Islam has another one. So you find that each one is a different at different places. What is also important about the religion is that what may be written in the books or taught is very different from the way people pragmatically live the religion. And there they may have a lot of flexibility available. Now, what happens because of this new technologies where embryo is fertilized outside? You'll find that from where you are getting egg, from where you are getting semen, where you are getting whose womb you are using, all those things create a different kind of situation for the parenthood. So you have when you have a pregnancy, you talk about the genetic parent. You can talk about biological, which is also it's a gestational parenthood, biological gestational, and you also have what is called social parenthood, that who raises the child, and they are the ones who are the parents. So if you look at that part, you will find that there are quite a few contenders for the parenthood. You'll find that for mother, there's a genetic mother, there is gestational mother who carries the child, and the mother who brings up the child. They can be different, or there can be combination of two. In the normal circumstances, you'll find gestational mother and social mother same. But otherwise, you may have genetic mother and the social mother together. Or you may have only social mother if you are adopting a child. The fatherhood, genetic fatherhood, and the social fatherhood. There is no other categories there. But what is very important here is that the biological aspects have become very, very strong somehow in people's mind. And so the genetic parenthood, and particularly genetic fatherhood, taken precedence. And if you read most of the judgments and the laws, you will find that within biology, it is not the gestation that is given important, but it is the genetics that is given very important. And that is quite problematic, and it has a lot of consequences in social aspects. There are other variations of the parenthood, where woman who bears her own genetic grandchild. Again, this is having egg from the granddaughter or daughter, and the mother of the daughter is carrying her eggs. A woman who bears the genetic children of her parents, and postmenopausal pregnancies is another thing that we have found, because they use all the hormones are stimulated, and even postmenopausal phases pregnancies could be done. Reproduction by the same-sex couples and partners, which is very, very important issue. We'll come back to it again, but they also have really used this assisted reproduction in order to be parents. So all of these things that are happening are the traditional norms and morality of the society are really challenged in this, and that has also created challenges in the law. There's another aspect in this parenthood, and it is right of the offspring to know about who are the biological parents, and that's how it creates certain norms about the kind of record that should be maintained, so that when the child grows up and is adult and wants to find out about it, they have a right to do it. So this is what I think is the crux of what I was talking about, is that when you have a situation of multiple parents of an offspring, it becomes very, very important to determine who has the supremacy there. And that's how you'll find that there is a kind of a hierarchical structure developing. So there is a supremacy of genetic biological parenthood against the gestational biological parenthood. That means a surrogate mother who is bearing the child for the commissioning parents, she is a gestational mother, but she does not have any control over the offspring who is there. That means the genes, the people who have shared the genes there, they become very, very important. And that creates what is called genetic essentialism, that all biology is reduced to genes rather than the whole process of pregnancy and childbirth. And supremacy of all biological parenthoods against the social parenthood. That being a social parent is not considered to be as important or as credible as having a biological parents. And that's one of the reasons why there is a high demand for assisted reproduction as compared to having adopting children. Adoption of children is much more difficult and problematic as compared to going and getting the assisted reproduction. And the last thing is that this genetic supremacy gets translated in the marketplace as a supremacy of the commissioning and hiring parents, as against the gestational parent, that is the mother, the woman who is carrying the child. So all of them you will find has a recall to racism and the eugenics, because that is where it starts. What kind of characteristic that one is talking about, and saying is that the essential thing is the genes, and you must replicate your genes rather than have other genes as your children. Now here also there are challenges, like this is mitochondrial replacement therapy. I won't go into details of it, but there is a couple of sentences that I have given here, that if there is a disease gene there, then now gene editing technology is available where you can take out that part. This is part of the gene, and you can replace it with a healthy gene from the another person. In this case, what happens is that you are taking genetic material for more than 2 persons, in that child. Now, if you are having genetic material of more than 2 persons, then who is the primary parent of the child? If the genetic parenthood is the supreme one. And there is a whole debate that you'll find literature which talks about that it should be whether it should be determined on the amount of the quantity of the genetic material used. Whose genetic material is more in that child? So this is I sometimes I find some of the debate very absurd, but they are quite real because they are happening in terms of getting legal right of parenthood vis-a-vis the child. Now let us look at a few safety issues and then come to issue of exploitation and market and the regulation there. I'm not going to go into each one. I think one of the papers that I have circulated talks about it, that there are safety issues at various levels. So in order to get ovum from the woman, you require controlled ovarian stimulation. If you read the Assisted Reproductive Technology Act, it keeps talking about, it keeps telling that doctor should be very, very careful in ensuring that it is controlled and there is no hyperstimulation of the ovaries. Well, we have to stimulate the ovaries in order to create, in order for them to produce eggs, ovum, and then, take the ovum out. It's very important there. Another question is that how many ovums can you take out at a time in one cycle of the ovarian stimulation? Again, that, and couple of cases of death of women who were donating the gametes have taken place because of the ovarian hyperstimulation. One, I think, in Delhi, one in Bombay. So this is not something that one can take it lightly. It is very, very important, and the person who donates it can have consequences. There are also, risk factors related to ICSI, that is intracytoplasmic sperm injection, when the sperm is to be injected into the ovum in order to fertilize it. Then this fertilized embryo is to be kept in a culture medium, because it is IVF, it is done in the laboratory. Then how long it should be kept? What kind of culture medium is used and how it can have impact when it is implanted in the woman's womb. So this is there's a whole range of issues and risks involved there. Then there are risks related to the embryo manipulation. So when you all these things done, they want to find out not just my gene, but I want to ensure that all the gametes which are there, they are not having any disease. So genetic screening is carried out of this of the gametes. And so it is a pre-implantation embryo manipulation by doing this genetic diagnosis. Now, in order to do that, you may have to take very tiny biopsy, or there may be other ways, but there are different ways of doing it. But in all of them, you are manipulating that embryo, and what kind of risk that causes. And ultimately, you transfer the embryo from the laboratory to the uterus of the woman, either the commissioning woman or in the surrogate. And while doing this transfer, there are certain risks involved. There are also issues about how many embryos at a time you can transfer to the woman. This is another problem. In Indian law at the moment says that maximum you can transfer is 3. But there are instances where there are large number of more than 3 embryos were transferred. Once you do that, because it has to be done, because all of them don't get implanted. Some will just go away, and get vested. So when those more than one gets implanted, you have to make a choice whether you are going to have more than one childbirth or you want only one child. So the remaining one which have got implanted, they have to be reduced. They have to be thrown out. So there is another procedure involved called reduction, where the excess embryos are shedded. So these are all kind of procedures which are carried out, which are very challenging. The another part of the risk factor is that the success rate, starting from the ovarian stimulation and taking over and implantation, the success rate is not very high as it is made out to be. Maybe 25 to 30%. That means a person who wants to use this technology may have to go through this procedure multiple times in order to get the desired results. So this is another problem. That also has a problem of money involved, because each time you do it, it costs you exact amount as the previous time. Now, coming to the whole market and the issue of exploitation, and that is where I think Indian law comes in, and it also comes in where LGBTQI people will have access to it or not. This term is used in morally, ethically neutral sense also. Exploitation, that I'm a good singer, so I exploit my voice and earn more money. But what is very important morally or ethically, the exploitation is bad when it is unfair taking of the advantage. Exploitation means taking advantage, but it is its connotation become pejorative when it is unfair advantage that is taken. And normally when we talk about unfair advantages, it means there are two, one of the two or all, one of the three or all three factors are involved, that it creates risk and causes harm to the person. Another one is that a person is deceived, not provided information about what kind of risks are involved. And third is that the advantage that is taken is not with fair benefit. There is an exploitation in terms of benefit, that you are not giving or sharing enough with the person, and so there is injustice there. If there are three aspects are involved, then this relationship between those who are commissioning and those who are working as surrogate will become exploitative. So we have to keep that in mind. That is how, to what extent they understand, what extent the measures are taken in order to prevent harm and to ensure that they are properly remunerated. All of them needs to go together in order to reduce exploitation in this manner. So this is another philosopher who is talking about mutually advantageous exploitation, who says that this relationship, which is unequal, because most of the time you'll find that commissioning parents are rich, and the person, a woman who is acting as a surrogate, is normally poor or of lower caste or minorities, who is oppressed people there, and so they do it because they find some advantage in this action. But that does not mean that it is fair. Despite whatever you pay and whatever you do, it remains unfair. And because of that, what it says, that since there are certain advantages, please don't completely, prohibit the surrogacy, but allow them under certain regulation. And so I think that is a very strong thing there. On the other hand, it also, this philosophers that I have quoted, they allow commercial interaction, a transaction, while our current law has taken out the commercial transaction. So that is another part of it, and we have to see whether this is going to stop the exploitation or not. So what has happened in India? This is my last section. I'll go through very quickly so that we have time to have some question. This Surrogacy as well as Assisted Reproductive Technology Act, both of them constitute national and state level boards and appropriate authorities. They are going to register all the centers where these things are carried out. It provides a standard. If you read this to law and the rules under it, it provides a standard which clinic can have. So in clinic, what should be there? What are the competencies of the doctors? What kind of doctors are required? All kind of information that is provided. So it is also a standard setting law, and it is also a kind of a regulation to implement those standards in the clinics, laboratories, and the biobanks and other places, and the surrogacy clinics. So it says that during surrogacy period, no abortion is allowed. The woman who is acting as a surrogate cannot do it, and it does not allow sex selection. The other thing which is very, very important, and which is a big setback to the LGBTQ community in India, is that those who are commissioning the child, they should be legally married man and woman. So there cannot be same-sex, the couple going and getting it, as well as other people. So this is a very, very, very problematic. This is an article recently published. A lawyer who has studied the bioethics has written it. It says about how the queer Indians are going to have a bleak future due to this law. It also says that the woman who is asking for surrogacy, she must show that she is having a medical necessity, that she cannot carry the child. And it should be done only on the altruistic purpose. No commercial transaction will be allowed, and that means only near friends, near relatives, and the friends will have to do it. The commissioning parents will require a certificate of essentiality. They have to go to the district medical board to get the certificate of the medical conditions. They have to buy insurance for the surrogate mother. And there are age limit for intending couple. They are married, and their age limit, and they should not have any surviving child when they go for the surrogacy services. Surrogate mother has also certain regulation, and surrogate mother means the woman who agrees to act and who is genetically related to the so she has to obtain an eligibility certificate from an appropriate authority, and she should be an ever married woman having a child of her own, and within certain age category, and she should not, her gametes or her egg cannot be used for the surrogacy act. The woman can act as surrogate mother only once in her lifetime. Again, that is a big restriction that is made. Some of them are in terms of health benefits may look good, but at the same time, you'll find that the whole idea of the law is to reduce it as much as possible. And so one has to go for more altruistic women who are ready to provide the services to the couple. Written informed consent in the prescribed format is required, but even after signing that, she can withdraw only before the implantation of human embryo. Once it is implanted in the womb of the woman, for 9 months, she's out. She just cannot say that I'm going to withdraw my informed consent. So this is binding her. Intending couple or intending women shall not abandon the child born out of surrogacy procedure for any reason. So this is another thing, binding thing is child born out of surrogacy procedure deemed to be the the child of the intending couples or intending women. So there is a legal right to provide it there. Then there is a law called Assisted Reproductive Technology Act and the rules. The rules came out very recently. Here, there are certain measures put in place in order to reduce the risks. They say that not more than 3 egg or embryos may be placed, not more than 3 embryos may be placed in the womb of the woman. A woman shall not be treated with garments and embryos of more than one man or woman during one treatment cycle. That means in the one treatment cycle, you use only one person's eggs or gametes, eggs or semen. Shall never mix semen from 2 individuals. Embryo shall not be split or used for twinning. One embryo can be splitted up and used for more time. That is not allowed. And gamete collections professionally done only if there is a consent of the commissioning couple. Otherwise, it should not be done, and should not use the ovum derived from the fetus. There is a pre-implantation genetic diagnosis allowed here, but it is for detection of the genetic diseases. Sex selection and any kind of things related to that is completely banned under this. And there is an age limit for taking semen from males and for eggs or oocytes from the females. There is also screening of the donors for the diseases of certain kind, and shall not supply the sperm or oocyte of a single donor to more than one commissioning couples. Otherwise, there has been always a lot of confusion about whose biological material was used. And one oocyte donor shall donate oocyte only once in her life, and not more. Oocyte can be retrieved from oocyte donor, not more than 7. So here the limit is put that if woman is stimulation is done, and she can donate only once in a life, and one cycle only 7 oocyte can be harvested. Cell transfer and use of gametes and zygotes and embryo for any part of the country and in the world is a ban. It is completely prohibited. That means commercial activities around this, as well as international transfer of this material is no longer allowed. This is the last slide. What it has done is that assisted reproduction is available only for the altruistic purpose. And the thing is, as far as surrogacy is concerned, whether such altruism will exist. And those women who are supposed to be not, coming forward to become surrogate out of altruism, what kind of pressure they will be coming into. And that's where the gender dimension will come out very strongly. That who are the women in the family who will come under pressure to volunteer to be surrogates. And I think there is in coming time we'll be knowing more about it, and hopefully the implementation of this law will be done in a more sensitive manner. At the same time, I think there is a very big area of advocacy about the way society should make arrangement for providing assisted reproduction to the LGBTQ community. The peers should have certain rights in relation to this, which are completely ignored in this law. Thank you very much. I'll just stop sharing, and then we can have whatever question you have.
Thank you so much, sir, for providing us with the presentation and giving a deep analysis on key areas related to reproductive techniques. Now, I would request the panelists.
Hello, Dr. Meena Vasan. Dr. Singh.
Ma'am, Yeah, I would like to call upon the panelists.
You are not audible.
Hello? Hello?
Yeah, okay, go ahead.
Thank you, sir, for the presentation. And now I would like to call upon the panelists to provide some key comments for the presentation of Dr. Amar Jasani. And maybe we can start with Professor Veena with her comments. Ma'am, please.
Yeah, okay. Thank you very much. And like always, I appreciate Dr. Amar's starting threadbare and dissecting the issues before us. A very complex matter, but slide by slide, he builds up like how you build a construction or a wall brick by brick. So he started with the reproductive right in the larger area where you also have a right not to have a child, which is not much spoken or not very much popular, and also brought into the social context of how literally after marriage fertility is taken for granted. And then there is immediately the study relating to the infertility, where he talked about the unexplained causes of infertility and other causes, but yet lot of money gets invested into surrogacy and other artificial reproductive techniques, whereby the research on the infertility is not very popular. Then he went on to talk about the embryo, position of the embryo, because if you take a personhood, then you will not likely to cause abortion. So one takes also property view that okay, it is nothing, it doesn't have any status. He also described the uniqueness of a embryo, and especially when you look at it from the human person approach and the human being approach as a, but anyway, in all cases it does not even get its right equal to the child or a fetus, but less than that. And then he talked about how we look about genetic essentiality. At the end of it, ultimately, are they genetic parents? How that has got more superiority, and also biological parenthood against social parenthood. Many parents may bring up children, but somewhere the biology triumphs. So, and also the market supremacy, that who can afford, who can go, who can take treatment, and who can do it, and it is not need based. And he brought into picture, especially when you talk of removing a maternal DNA, then you have an additional parent, you have a mother, father, you have an additional person, then what is the local status or a status for that? And regarding the different issues of pre-implantation techniques, whether it's exploitative in research, is it exploitative, and what is the disrespect to the fetus, and so on. He brought on to the latest today, the as it stands today, the sections that deal with surrogacy, and where how do you choose a person who is a donor, how do you choose a surrogate mother, and also what are the restrictions for the sale. In all, he also brought in a very sensitive issue that all these literally are not meant for transgender couple or not meant for homosexual couple. So it is like when you make a rule, you systematically, for some reason unknown to everybody, or maybe it's only discriminatory outright, they are left out of any benefit from this. So he brought this out very well. So thank you, Amar, for the presentation.
Thank you, ma'am. Now I would like to call upon our course advisor, Professor Vibhuti Patel, to contribute with some comments.
Yeah. I think it was a very, very comprehensive presentation with all the socio-legal and ethical dimensions Dr. Amar Jasani has covered. My main query was about the global comparison. What are the legal provisions in different countries, and can we learn in Indian context? So that would be, and which is the most ethical way of dealing with the issue of assisted reproduction. Because the LGBTQIA community, also everybody loves children. So can we humanize this whole process of demand and supply side?
Thank you, ma'am. I would request all the participants to actively take part in it, and please post their questions on Q&A box.
And some have already written in the chat box.
Yes, ma'am. There are some.
Sunita Singh is written in the chat box. We
Okay,
can
ma'am.
copy paste it on.
Yes, ma'am. I'll take that later. First, we can address the Q&A box questions.
Yeah.
Sir, the first question is by Sagar Ji. He is asking, please guide on the rules, guidelines in India for adoption of children by homosexual couples.
Well, I just don't know much about the adoption procedure. Perhaps Vibhuti or Veena might be knowing about it. Any idea? I have no idea. I have not looked at the laws related to abortion.
Some years back, adoption was not open for homosexual couple. I don't know if the latest, but there has been inquiries. Even if the normal couple, when cisgender want to adopt, the rules have been so tortuous, so that if they're working, then it's sometimes difficult for them. The agency decides they cannot adopt. So in homosexual, at least some years back, at October 8-9 years back, I was aware that they were not allowed. I've not looked up into the latest.
What I know is that the single women are given adoption. So at least in our own circle, in our own friends, I know Neha Madiwala who had adopted a girl, and that is without marriage and without having a husband. So I think that is available. But as far as those who are having same-sex relationship or who are transgender and other gender people, I doubt that they have. The adoption laws provide them space, unless they do not disclose it and go as one individual and then try to have a child adopted. But if you want, I can do more research on it and then let you know. At the moment, I don't have any information.
Sir, there is another question by Susrita Ji, and she's asking, sir, for surrogacy, is there any clause? Is the consent of surrogate woman's husband necessary before she accepts to be a surrogate?
Well, as far as I read this law only, again yesterday, and I don't think there is any provision for this. That there has to be, but what is required is that there has to be a consent of the surrogate woman, mother, and there has to be certification or approval by an appropriate authority. These two things are mentioned, but there is no mention of the husband of the surrogate person. It also says that a surrogate woman who gives consent cannot withdraw the consent after the implantation is done. So these are the things they have mentioned, but I don't think the husband is given anything in this.
Okay, thank you, sir. And there's another question from Sunita Singh Ji. The participant is asking, what is the role of the art bank in the selection and replenishment of oocyte donors?
The oocyte donors, which I am observing in my research, are donating on regular basis, right? That's what Sunita Singh is saying. Although they are aware of the adverse effects of it and the new law, they still do it. When you look at the social and economic state, it is very bad. They often face domestic violence. So this is the major problem in this entire transaction. There, as I said, that those who are commissioning, those who need this services, they all have money. They are normally coming from better off background, and all those who are providing these services, particularly women, because there are men also who provide semen, but they are not anyway exploited in this process. But the women are completely at the mercy because they need to earn from it. And that's how for every law, this is the problem, that law may be good, but law may not get implemented. Or there is maybe a lot of corruption in the implementation. This is true. You will find, transplantation of organ law, where also the commercial transaction has been prohibited. And yet you will find that there are different ways in which the law is violated at the ground level. So yes, what you are saying is happening. These laws are very new, the 2021 and 2022, we got the rules of the law. So it is too early to say how they will be they'll be implemented. But I'm sure, like Organ Transplantation Act, every few years there'll be big scandals related to this. Simply because there are people who are poor and they are ready to take risk, and there are rich people who lack empathy and sensitivity, who don't mind exploiting them. So this is the situation against which we have to fight. I do like abolition of commercial aspect from this law. What I don't agree with this law is saying that it can be used only by married man and woman. If that clause is taken out, it will immediately open this entire process to the other genders too, and they can people who are in other type of relationship. I say it says legally married should be there. That means even those couples who are in live-in relationship, they will not be able to use it. So, it's very, very restrictive. And it looks that the mindset of the policymakers was that if you restrict it, all those controversial aspects of this law will disappear. Of this process will disappear. That doesn't happen. Your second question is, what is the role of the ART bank in selection and replenishment of oversight donor? Now, the banks, there is a separate section in the Act. If you just go through it, most of these things that are talked about, that how many ovum can be harvested in one cycle and all, how many times a person can donate, they all are also made applicable to the ART bank. So you'll find that it has this issue, and they play a role by as you said, they are banks because they store them and they make available as per the requirement. And your second concern is how and who would like to be surrogates if there is no commercial transaction. This is what I was talking about, that if you don't have commercial transaction, that means you will have to convince somebody from your family, extended family, or close friend circle. Now, is this good or bad? I don't know. As I said, that altruism in a true sense is very, very difficult to get in current society because everything is commercialized, transaction based. But at the same time, I would say that it will make it necessary for the couple who is or a person who is seeking a surrogate to link up with the surrogate. Today, what happens in the market transaction, I don't even have to know about what is the background of the surrogate, except where my child is going to be affected. That means my surrogate should not be deceased. My surrogate should be of certain color or whatever. I mean, whose gametes I'm taking. So you may try to find out the physical characteristic of the person who is donating gamete. But as far as surrogate is concerned, you want to see only this part, not this is. When she is carrying the child, she doesn't smoke. She will not take alcohol. She will not take drug without medical, prescription from the right kind of doctor that is taking care of her. All those things you will find there. So you are not concerned about the woman. You are concerned about a womb, and that creates problem. So I hope to an extent this lack of, by taking commerce out of it, if it makes those who really desire a child should also through surrogacy, they should have humility to link up and connect with the woman who is providing these services and create a relationship with her. Now, one may say that, well, it's an emotional relationship, create a lot of problem and all kind of stuff, but then she is there and she has a biological role to play. So like any other, like say if the child grows up and wants to find out who is the biological mother, and then she has a right to find out. Same way, I think the couples should create some kind of concern for that. I think that for us may be useful. That is what I can say at the most. And but they will have to find surrogates from people who really love them or are in connection with them. And I hope, as I said, as it will happen in a traditional family, the other women of the family, you know, a sister-in-law or somebody else, you know, they will come under pressure. Even sister will come under pressure to act as the surrogate, and that will be really a problem.
There is one participant who has raised her hand, Praveena Mukherjee. Please raise your question to sir.
Praveena Mukherjee has raised hand. You can unmute yourself and speak. Praveena Mukherjee, your question is there. What happens if the couple drops the plan for accepting the child mid-surrogate pregnancy?
Well, the current law, the new law that has come up, they say that they cannot refuse it. Now, how they will enforce it is the one that we need to see. Now, how physically you can cause them, that is one problem. The other is that will it be only based on, you know, having some penalty against them, that is they pay fines or something like that if they refuse, or it will be taken as a criminal action. But if they refuse, you know, irrespective of whatever action is taken by the government against them or the law against them, what happens to the child? Will child be an abandoned child? And you will find that in the current law, there is a section talking about the abandoned child and then how to take care of it. But then it is just like taking care of an orphan child, because unless the gestational mother, the surrogate woman, takes her, you know, but she has no, you know, she is not supposed to have. She has already given up that right. She is the orphan child, you know, abandoned child. You know, this problem is still going to remain. They believe that by keeping this strict, they will have less problem. But there are also instances where during the gestation period, the commissioning parents died, you know, in an accident or in a sudden illness. What happens after that, you know? These are the problems still going to remain and to be solved in a very pragmatic manner. So this law is not going to solve all the problems which were there earlier. It can only provide a framework to act on the subject at the moment. Yeah.
Sir, Alka
Have you
Dhupak.
answered Alka Dhupkar's question?
No, that's pending,
You
ma'am.
talked about infertility, one of the known and misdiagnosed causes is endometriosis. But normally, most of the girls and women suffering from endometriosis are neglected, saying the period pain is normal. Many gynecologists are very, very judgmental, ethically questionable behavior that they're into bracket. Without proper diagnosis, women keep suffering and pressure of fertility is high. What can be done?
Well, I see there is I think Ketki was also talking about it on the gender issue. The medicine is having a lot of problems. Gender blindness is a major issue. I remember way back in early 80s, and even in a meeting of medico friend circle, when we were discussing about prejudices of the medical people against women in the medical care, there were a lot of problem of understanding. So it still remains. So endometriosis is, as far as I remember, because I'm not practicing, so my medicine is very, very dated. But it is a significant problem. Unlike just having pain, which is for you know, because of some other problem, which may be easily taken care of. Maybe reproductive tract infections and those kind of stuff. But endometriosis is a condition if it is present. I remember some people asking me, women asking me whether they should go to the biobank and preserve their home in case they are not able to become pregnant again because of the worsening condition of endometriosis. So I exactly know, but the very judgmental way of a gynecologist or doctors is definitely shows that there is a gender problem in medical education and clinical practice. I think you had a separate session where Sangeeta and Padma talked about gender and medical education and how prejudicial the medical profession can be on the gender issue. And that is true also on the caste issue and the religion issue, which is still not looked at as much. And also on queer issues, this LGBTQ issue. So there is a lot of re-education of the medical profession needed on the gender. How to sensitize people of small town like ours about surrogacy, as one of my friends has to go out of the state for surrogacy because such procedures are not suggested by our doctors here. Well, surrogacy is not a, it require what is happening today about the assisted reproduction clinics all over the country is that the well-equipped clinics are located in main big cities, and the small cities they have created the smaller clinics which not having enough support system. So I don't know what is the problem in your area, but if the clinic, assisted reproduction clinic, is registered with the new law, and if the surrogacy clinic also is registered with the surrogacy law, then and having all the facilities as prescribed in the current law is available, then it will be possible for them to provide this service. Otherwise, it is not possible. Otherwise, it is better to ensure that it is done at the right place, because they require IVF facility, and for that you require certain kind of medical know-how and technology, and also for harvesting the ovoms and all, the number of medicine required. I was doing a study on assisted reproduction technology, and I found that in large number of small cities, the pharmaceutical companies which provide the drugs, different kind of drugs which are used in assisted reproduction, they do a lot of investment to help the doctors to set up the surrogate, the assisted reproduction clinic. And the bigger clinics in the big cities, they send visiting doctors there, particularly embryologists who are very highly qualified ones. They are like traveling embryologists. They go city to city to help out in this thing. So it's a different kind of business model that has emerged, and that way I find that because of this separation between highly equipped institution and the peripheral institution, the risk factor increases. Now, whether this law will homogenize them and ensure that each service that is provided by the clinic in the small town has a full facilities and competent medical human power available, then it is different. But as of now, I have no idea, because this is a new law, and I don't know how it is going to play out in coming time.
I think we have covered the questions for now.
Dr. Meenakshi Gopinathan's question is that the provision that surrogate women cannot withdraw consent, denying her complete autonomy of her body and also choice. Can it not be made along the same line as MTP?
Well, this they say that you cannot that woman cannot withdraw the consent after embryo is implanted in her uterus. And at the same time, the law says that the surrogate mother cannot take resort to the medical termination of pregnancy. So what has happened is that this law actually takes away the right of medical termination of this woman. So if she is pregnant as a surrogate, she is, whatever decisions are to be taken are controlled by the medical authority that is over her and the commissioning parent. They are the ones who call shots there. And so she cannot just, and this is what this law does. And that way you can definitely say that this law is pitted completely against the gestational mother, who is a surrogate mother. And that's why I was emphasizing in my presentation earlier that at present the biological motherhood is made equivalent to the genetic motherhood, and genetic motherhood is made completely supreme as against all other forms of the motherhood. So even gestational motherhood is given secondary importance. So this law is that way. In terms of its understanding of biology is very strongly in favor of genetics. And that, as I said, that it has a very strong implication for saying that my child will be of my blood only. A strongly fascistic understanding of the way we look at the world, and say that purity of my blood is very, very important, and that purity comes through genes. So it's a genetic determinism or primacy of genes that is being talked about. Although when gestational mother is different and her body blood is going to actually nurture this child for 9 months, and that is completely ignored, and her contribution in the in the production of the child is completely made secondary as compared to the the genetic parents or commissioning parents. So it's absolutely bad. I just can't agree with it. I feel that somebody has to fight, but whether that this is the law passed by this, and the courts may not intervene so easily. So we'll have to find a way of doing it. Or some surrogate mothers may have to raise the issue at some stage about having right to abortion. For 9 months, the right to abortion is suspended. For 9 months, their autonomy is suspended about withdrawing from it. Withdrawing means going through abortion. That is the only way you can withdraw, because that is once the child is aborted, then and then you can get out of it. Otherwise, you are still stuck to that. That's the problem. Or she wants to have her own child. That child is her own and doesn't want to give it. But that is there also. The contract, the market transaction is made more supreme than her desire. So it's a law which has certain good aspect. As I said, that commercialism is taken out. At least formally, it is not allowed. That way, one can say. And then there is a regulation brought in saying that all clinics will be registered. Their standards are at least made public. We can keep fighting for higher standards, but they are at least known now that what they will require, and what kind of doctors should be there, and what should be their training, and what should be their assistance. All those things are now spelled out. So those things are good, but it still has the same patriarchal mindset, which determines the human essence by looking at genes rather than the human beings. So that is how we have at the moment. Anyway, that is also my conclusion. I don't have to do separate concluding remarks. Yeah.
I think we
Thank you, sir. I would like to call upon Veena ma'am to add some comments.
It's been very interesting, especially the discussion regarding the surrogacy, the choice of the woman, the autonomy given to her, especially because since I've already covered the initial part of it, this is also important to note that when the child is born and it is not taken by the commissioned parents, like it happened in baby Gami in Thailand, the Australian couple had commissioned the kid, and then there was this Thai lady. She had twins, a boy and a girl, and the boy, baby Gami, was I think he had a Down syndrome. So the parents did not take it; they just took the girl and went away. And then the Australian court had decided that because the commissioning father was a sex offender and he was in for offense against the boys, he better not take this child. And then in any case, there was a later on a charity set up to look after the boy, and he continues to be with this lady, mother who was a surrogate mother. So but then many a times such things do happen, and then we should ask ourselves, do you have the sensitivity to care for the child? Do we make up our decision caring for the child or just a punitive measure for the person who has done it? So, because ultimately, the long and short of it, the way we are going, we are not caring much for the transgender, lesbian, gay, homosexual, whatever, because we only stick to cisgender. So, tomorrow, should the commissioning parents back out from the deal, it will be more of a punitive measure for the parents, but nothing for the child. So, somewhere at the back of our heart, our decision should also be, how then do we formalize such a thing that the child is brought up with the dignity as well as a right for all the fundamental rights as well for human flourishing that are required. So that's what.
There is one question in the chat box by Dr. Simi Mehta that is about the health of a surrogate. Could you share your views on where does the responsibility for upkeep of health of surrogate women lie?
Well, what the law has done at the moment is that the commissioning parents are and the doctors or the clinic which is involved there, they are made responsible for the health, and they are also asked to buy insurance cover for her, so that any other extra expenses are there, they are covered under the insurance and provide support. Or if there is anything goes wrong there, during the maternal period or during the childbirth, that coverage is provided. So that I think is taken care of. But how much insurance will be there? Will the insurance be different at different places for different kind of people, or it will be capped as per the bargaining power? Those issues are to be looked at more closely. So what has happened that at the moment these new laws are there, and we are looking at the big things that are given in it. We are not going into the finer details. So if we want to have a separate session on the law itself, then we can go into that. But it should be the responsibility of the commissioning father, because commissioning parents, because they are the ones who are calling shot. You don't give autonomy to the woman to take care of her health by going to any doctor she likes. She has to take advice only of the doctors who are nominated there, because they are interested in ensuring that the fetus is not harmed in any way. So any drug that is given, that must be reported, that must be scrutinized by them. Without that, she cannot have it. So as I said, that for 9 months, it is almost giving up most of the autonomy of the person. She cannot make free choices there. So that remains a major problem, and that will remain in most of the surrogacies, unless we do not provide such a supremacy to the commissioning parent, and say that a surrogate mother should have a right to withdraw without abortion and to have that child for herself if she changes her mind. Now, if you do that, the power of the autonomy of the mother will be justice and mother will be reestablished. But the entire transaction is based on the power of the commissioning parents, and once that is gone, but one last point that I want to make is that one missing thing in assisted reproduction is that the public sector or the government is not investing in it. It is completely left as a tertiary care in the private sector. Now, public sector is doing little bit, but that is in very, very primitive. The time in my time, which we small thing that we were doing, that if there is a causes like say blockage of the fallopian tube, then you can do a small surgery and take out the blockage, and the woman may conceive. But they are not doing this complicated assisted reproductive services in the public sector. That is where I think some services need to shift in order to bring more pressure on the private sector to be disciplined and more ethical. Because today they are completely in charge of the whole stuff, and they have a very powerful lobby. Because they are not just those hospitals and clinics. They are also pharmaceutical companies. They are also related to the companies which are producing medical devices. Because each, I don't know how many of you have gone into the assisted reproduction, clinic and seen the kind of technology they use. They are very, very sophisticated technologies they are using, and each one costs huge amount of money. And that investment is coming from big corporates, including pharmaceutical corporates, and the doctors are getting their share in it. And that's how most of these clinics are run, and that's how they are very, very powerful. And that's how the commissioning parents' final say in all the matter is not taken out. So that requires a larger movement in order to really fight against. But when you start fighting, you remember one thing, that you will have to principally agree that doing surrogacy is not morally bad. It is the way it is being done may become morally bad. An Indian cultural ethos and moral ethos have been very, very open in it. You'll find in our legends, lot of stories about surrogacy. So it's not assisted reproduction is also very, very commonly described in Indian mythology. So that way, if that is accepted, then the rest of the thing we will be able to take. It's like sex work. That you will be able to fight for the safety of the sex workers. You'll be able to fight for better health rights as well as other socio-economic rights of theirs. If you accept that, well, they are doing it, and I don't pass them, don't say that they are bad people, but I help them to improve their life. If we do that, then we should be able to help the surrogates much, much better. But if we say that they are wrong, bad, they are the women who are of loose character, that is why they are doing it, then it is a problem, So they suffer from a lot of social stigma. Being surrogate is not that easy for a person, particularly in a smaller town and other places where things become very easily known. So yeah, it's a very difficult life for them.
Thank you, sir, for such an enriching deliberation. Now I would like to call upon our next expert for the last session, Ms. Brunel D'Souza. Ms. D'Souza is Assistant Professor and Chairperson at the Center for Health and Mental Health, School of Social Work, GISC, Mumbai. Ma'am, we welcome you, and please go ahead with your presentation. Over to you, ma'am. Ma'am, please unmute yourself.
Is the presentation visible?
Yes, ma'am.
Well, it's in working mode. Make it a slideshow.
Yeah, 1 minute. I'll just start it. Okay, just a moment. Let me just stop share. Is it now visible?
Yes, ma'am. You can go full screen. Yes. From the below. Bottom.
How do I do that?
Yeah, just behind that, right? Just the right of that, where your cursor is. Yeah, just click on that.
Okay.
Yeah, it's working. Yes.
Okay. Yeah. So good evening to everyone. And I was, I have basically been tasked with discussing with all of you, basically handling this topic of gender and nutrition. Okay. I will begin with, I've basically divided my session into, 3 or 4 main parts. The first is an introduction. Then we look at the global context. We look at the context of nutrition in India. And then we look at the specificities of gender and nutrition. And then some concluding comments before I go on to the recommendations. Okay. So as I begin with saying here that food is not an option. This is something that should not be an option for any human being. Eating nutritious meals is necessary for both survival and to thrive. And the right to food is an integral part of the right to life. I think this is something which has also is also very clearly recognized in the context of our own our own country, in the context of the right to life. The Supreme Court has very clearly stated this also in the Indian context, that the right to life is not just about survival, it's about the right to health, it's the right to water, it's the right to adequate and nutritious food. But food and nutrition insecurity, continues to remain a serious global challenge. And there are many global drivers for this. One is climate change, economic slowdowns and downturns, urbanization, greater armed conflict, and the globalization of unhealthy diets, particularly, in the global south and north, but we're really concerned about our own context, and therefore we are referring to under-resourced countries. And food insecurity is rapidly becoming an even greater challenge for those living in poverty and in those societies and economies where you see inequality rising. Now, the SDG goal is about zero hunger, okay? But we've seen that the world has not been progressing either towards ensuring access to safe, nutritious, and sufficient food for people all year round, which is basically SDG target 2.1, or to eradicating all forms of malnutrition. Of course, we've made, there has been phenomenal, change and progress. But, there is still a lot to be done. And when we're talking about access to safe, nutritious, and sufficient food for all people all year round, or to eradicating all forms of malnutrition, we still have a long way to go. And the COVID pandemic, as we've all seen, has made the progress towards SDG 2 even steeper, not just in India, but for many parts of the world, especially the developing world. And, recent data shows that about 660 million people may still face hunger in 2030. In part, of course, due to the lasting effects of the COVID-19 pandemic on global food security. It is said that 30 million more people would be living food insecure lives, or will face hunger, not just food insecurity, but hunger. And this is much more than in a scenario in which the pandemic, than in a scenario in which the pandemic had not occurred. So perhaps if the pandemic had not occurred, we would see a different figure, but then that figure by itself also, would not be, is still a huge figure. Okay, 660 million people, to face hunger in 2030, sorry, and we are talking about hunger. So definitely bold actions are needed, especially to address major drivers of food insecurity and malnutrition, and the inequalities affecting the access of millions to food or hunger. So this is very important. We need bold actions. We need bold actions by governments. We need bold actions by the global community, by civil society organizations, by academia, to address the drivers of food insecurity and malnutrition. Okay, and to address the inequalities affecting access to food. Now, we come to the Indian context. So that was, basically my introductory comments about the global situation, because I basically want to embed my discussion on food, on gender and nutrition, within these larger global and national context. Okay. So India has the dubious distinction of having the world's largest population with food insecurity. And this has been despite, robust economic growth in the past decades, but we haven't been able to reduce undernutrition the way we should be able to do so. I mean, India, at the cusp of, the World Bank and the IMF had basically said that in 2019, India would become the world's 5th largest economy, even surpassing UK and France. Of course, today the IMF data pushes India back to the 6th position. Okay, and further to number 7 in 2021. But still, we have been, one of the fastest wealth creators in the world in recent times. But of course, that wealth creation, we all know from various studies and evidence data, the Oxfam report, is something that has really not addressed issues of inequality. In fact, inequality is only sharpened. And food insecurity and undernutrition, malnutrition continue to remain major challenges. Now we see that the household food insecurity has actually worsened in many parts of the country since the pandemic. It has affected, many families, many communities, especially the poor and the marginalized. And we continue to face a considerable burden of malnutrition. So actually, with nearly 195 million undernourished people, India shares 1/4 of the global hunger burden. Nearly 47 million, or 4 out of 10 children in India, are not meeting their full human potential because of chronic undernutrition or stunting. And this is something that should really disturb us, friends, okay? Because it really means that, you'll have generations of people, of children who will not have the opportunity to fully grow, to fully thrive, to fully, grab all the potential that life has to offer, okay? Now, stunting is a huge challenge in India, and this is, stunting, wasting, continue to remain huge challenges. So according to NFHS 5, the number of children under 5 years who are stunted between 2019 to 2021 is 35%, and the number of children who are underweight is 32%. Extremely. So we are talking that, almost 1/3 of Indian children, are, affected by stunting and are underweight. We have made limited progress also in improving levels of wasting, which remains 17.3% for children under the ages and under 5 years of age. So wasting, which is also known as called acute malnutrition, we know some of the effects of wasting. Okay, it decreases immunity and increases susceptibility to infectious diseases at an early age, and so can be life-threatening. Then there are, of course, other nutritional deficiencies which remain another area of concern for young children. And micronutrient deficiency, which is also called as hidden hunger of iron, vitamin A, iodine, zinc, folate, vitamin B12 and vitamin D. All of this affects the health, growth and learning ability of the individual and is a major contributor to childhood mortality. Now, the impacts of malnutrition, undernutrition, are multi-generational. Okay, as malnourished girls and children often give birth to low birth weight infants. Now, another important factor that we need to realize is that the social position of a person, okay, is also an extremely critical factor in nutritional inequality. And there is ample evidence to show that scheduled castes, scheduled tribes, and Muslims carry a higher burden of malnutrition. So we are looking at not just poverty and its intersections with gender, but we're also looking at poverty and its intersections with caste, tribe, and religion. And of course, women, coming from poor backgrounds, from scheduled caste backgrounds, scheduled tribe backgrounds, and Muslim women will also, and girl children, Muslim women, children, and girl children in particular, will also carry a higher burden of malnutrition. Okay, so and at the same time, we're also seeing an increase in the prevalence of overweight and obesity in children and adolescents in India, which of course has its own lifelong consequences for non-communicable diseases in adulthood. So so today in India, we are seeing basically a triple burden of malnourishment. We are seeing undernourishment, we are seeing micronutrient deficiencies, and we are seeing overweight trends. Now, this is about anemia among children and women remains a cause of concern. And so basically you see NFHS data which says that 50% of all women of reproductive age are anemic. And this is up from 53%, okay, in 2015 and 16. So you see that anemia is actually, has risen. And the number of anemic children under 5 has risen to 67.1% from 58% in the last survey. We're referring to NFHS 4. The percentage of anemic teenage girls between 15 to 19 has risen from 54% to 59%. And of course, you're also seeing the percentage of women who are obese, which according to NFHS 5 data has increased to 24% from 20%. And the percent of women who are overweight, with a body mass index more than 25 kgs per milli, it stood at 33.2% in urban areas, while it was 19.7% in rural areas. This basically shows you a comparison between NFHS 4 and NFHS 5. So you see that anemia has actually risen. Stunting continues to remain a serious problem, though it has marginally decreased. Wasting also has slightly decreased, but is still a major problem. It's a major problem when we're talking about 19% and 35% of our children, and about 7.73% of our children are severely wasted, and that has increased. While of course, overweight children who are overweight is also on the rise. Now, there are a number of reasons, there are multiple factors, and I think this is very important to discuss and understand before we, go on to the specific context of gender and nutrition. So one is, of course, these factors show significant interstate and intrastate disparities. So you see the prevalence of poverty and increasing inequality, okay, and which is an important thing. You see an inadequate availability of food grains and pulses. You see the absence of vital nutrients in the diets. In fact, there are studies that show that people are consuming fewer calories, cutting back protein calories, and increasing consumption of fats. And so this is an important issue. The absence of, as I said, vital nutrients in the diet, ineffective public distribution mechanisms, and unequal distribution. So very often, you don't have a public distribution system, whether it's of food grains or of, other nutritional programs, okay, which is really functioning and is accessible, especially to the poorest and most marginalized groups, okay? And of course, we also know about the relative status of women within the household, the lack of access to clean water and poor sanitation, as well as genetic and environmental causes. You also see that large tracts of farmlands in India have become barren due to imbalanced fertilizer use and excessive use of a single fertilizer, urea. Then you also have infrastructure developments and land use change in favor of industries and mining, which is already severely affecting the food and nutritional security of the country's poorest. And many of them actually are partly, forest dependent indigenous populations. So there is an entire macro context, because we often look at nutrition, from a very narrow perspective. We look at nutrition without adequately looking at the intersections and its political economy adequately. And it is very important for us to foreground that political economy, or to keep that political economy in the backdrop, because then we could then look at gender inequality and nutrition within this larger landscape, or this larger backdrop. So you also see that there is a delocalization of food supply and disruptions in food systems, which is also happening. People are losing access to farms, forests, and the commons. Okay. Then literature on agriculture and nutrition shows a positive correlation between cultivating food crops and nutritional security. So if you're cultivating food crops, you're going to keep some amount of that also for personal and family consumption, obviously, before selling it. And so there is a positive correlation between cultivating food crops and nutritional security. However, when we are coming, when we see that those the rural poor who are landless and who are engaged in subsistence farming, okay, they tend to suffer from chronic food insecurity. And within this rural poor, we see that almost, women are a very significant group, because in India, 85%, and this is not only true of India, okay, it's true of many parts of the world, especially the developing world, where you're seeing an increasing participation of women in agriculture, because men are now migrating, and it is women who are managing households and also farms and fields. In India, about 85% of rural women are engaged in agriculture. yet only 13% own land. Okay, so obviously women are you know, most women are in extremely, women involved in agriculture are in extremely vulnerable situations. Okay, and many of them are you know, work as agricultural labor, or who may be involved in subsistence farming, and therefore they are at a higher risk of chronic food insecurity. And we're seeing a slowing of agricultural growth because, and climate change, land degradation, and shrinking biodiversity. All of these are also going to have a bearing on food insecurity and in the country and even globally. And there's also a lack of concerted political will on the part of successive governments and existing systems, okay, and policy, you know, to address the issue. Okay, we don't take hunger, we don't take foods insecurity, we don't take nutrition insecurity as seriously as perhaps we take many other issues, you know, in the country, you know, I mean, it has, for example, there's hunger, there's food insecurity. Okay, you know, is it part of, you know, what you say, election manifestos? That, you know, is it part, you know, as much as, you know, other issues become part of election manifestos, why can't we ever dream of a hunger-free India, or, you know, an India where no one is food insecure or nutrition secure? And we have, you know, good programs, but these programs, these systems and policies have really not been able to deliver effective results. And we'll see, it's not that we don't have these programs, and I will discuss some of this as we go along. Now, the post-COVID situation, because we know that COVID has really impacted the lives and, you know, the what you say, has been a huge, you know, global humanitarian crisis and health crisis, a development crisis. And this is some data. So we saw, you know, post-COVID data that 77% households today are consuming less food than before. And, you know, and this was around April, May. So, you know, the pandemic really caused an immediate disruption and had an immediate impact on the food and nutritional security, because, you know, people had you know, I mean, for most people with limited savings or almost no savings, you know, the only way that they could cope, I mean, and we're talking about not the disruptions that came from the lockdown or the closure and things like that, but really, you know, over a period of time, didn't have money to basically, you know, manage even food, this thing. About 66% lost employment, okay? And you had, I mean, Hunger Watch, this is the Right to Food campaign, and this is Center for Sustainable Employment says 53% reported that their consumption of rice and wheat has decreased. So imagine, you know, the poor, you know, globally tend to eat a very, what you say, eat less diverse and monotonous cereal-based diets, okay, that are deficient in essential minerals and vitamins. And here you see even that cereal-based diet has become a challenge, okay. 64% reported that their consumption of dal has decreased, of which about 28% reported that it has decreased a lot. And 73% reported that their consumption of green vegetables had decreased, and for about 38% it had decreased a lot. And 17% said that they had consumed eggs and non-veg often before the lockdown. And among them, 91% said that their eggs, meat, and consumption had decreased in September and October, and a staggering 58% said it decreased a lot. Of course, because by then many people were reeling against, were experiencing severe economic shock, with the loss of livelihoods or, wages or reduction in wages. There were huge challenges, and food inflation, okay, has been up 7% on average from the first lockdown. So you see food inflation going up, but while people's incomes and livelihoods are shrinking. And yet you also saw mounting food grain stocks, about 110 million tons as on, lying there as on June 2021. When it could have been made available for people. And even the relief, even the minimalist, support or relief that was provided by Government of India and even many civil society organizations was largely cereal based. It was rice, it was wheat with some amount of dal, and so a very the diet that was provided even as relief was monotonous. It was really very limited in terms of nutritional value. In fact, Government of India was not even providing oil. The oil that went on, was part of many relief packets, was something which was really what civil society was doing. And you see that when you're looking at the global hunger index, India falls to 111 to 1116, and this doesn't really augur well. Okay, 101 from 116 countries, and it fell from its position. It was earlier 94, and it is now it was 101, and this is around 2020. This thing, and this doesn't really augur well for a country that, okay, at just in 2019 and even in 2020 was positioned as the 5th or the 6th largest economy in the world. Now, coming more specifically, with this backdrop, coming more specifically to the issue of gender and nutrition. Okay, so women play a very critical role in household and national food security. So not just in the household, okay, even nationally, as food producers, as household food managers, and of course, as consumers themselves. Okay, in many societies, women continue to face serious obstacles. Okay, and we know that from our own lived experiences. We know it from our work, from our research, from our engagement with communities, that women face serious obstacles. Okay, with regards to their, so basically what I would like to say here is that as a result of deep-seated gender discrimination, okay, women have experienced serious obstacles to household food security and nutrition, okay? And as a result, women experience difficulty in accessing and controlling resources despite being key players in food production in many developing countries. So while women are, really have a very, very critical role to play in food production, okay, because of deep-seated gender discrimination, okay, they experience major difficulties in accessing and controlling various resources. Okay, access to credit, access to decision making, and the like. Now, the high nutrition requirements. Okay, women also, give birth. They get pregnant. They give birth. They breastfeed, and along with the gender-based discrimination. Okay, so you're seeing that there are also physiological needs. There's pregnancy, and lactation, along with gender-based discrimination, which is experienced in many parts of the world, which makes women more prone to malnutrition. Okay, sorry, than men, and poor women actually suffer the brunt of it the most. Okay, and we see how gender inequality is linked to the prevalence of undernutrition and low birth weight in many countries of the world, but also in South Asia. Now, in agricultural communities, it is women who not only care for children, okay, but they also work in fields, especially, as I said earlier, in societies where urbanization is on the rise and men in rural communities are forced to migrate into cities for work. However, women lack access to land, they lack access to credit, education, and also agricultural inputs. Okay, there are many studies in India, okay, that show that women's engagement in agriculture is high and similar to men. But there is no relief, of course, but despite, women, participating in agriculture and women's participation in agriculture being very high and similar to men, there is no relief in the domestic activities for women, especially during peak agricultural seasons. And what studies have found, and this was a Tata Cornell Institute for Agriculture, at the Tata Cornell Institute for Agriculture and Nutrition had carried out this study in Maharashtra, showed that more engagement in agriculture in peak seasons is associated with a decline in nutrients. One of the authors, and I would like to quote her, more hours of farm work in peak season eats into the time and energy women would spend on cooking, especially during the evening meal preparation. They may choose to reduce cooking time, make dishes that take up less time to cook and require less effort. As the diversity in diets fall, this in turn can affect nutrients derived from these meals. Okay, so this is also, and since a number of women are in agriculture, these are important findings to note, because this has a bearing not just for the woman's own health and nutrient intake. Of course, that is important and is an important value by itself, but also for the nutrient, for the family's nutrition and health and well-being also. Now, you also see that landless women have no choice but to work as agricultural laborers in peak seasons. So these landless women, and who are often landless women, these are women coming from Dalit, Bahujan, and Muslim communities. Okay, so in addition to household work, they work as agricultural laborers in peak seasons, and they tend to face even worse nutritional deficits, while women with large land holdings can at least choose to hire labor and technology and reduce their time spent on the field and at home. Okay, and there have been a number of studies that show the relationship between land ownership, kharif paddy cultivation, or crop cultivation basically, and diets. So those who own lands, tend to have a greater nutritional and food security than those without lands, obviously. Okay, and so in Southern Asia and in Sub-Saharan Africa, women are more likely to experience obesity and other nutrition-related chronic diseases than men. And as I've said this earlier also, and this is found also in certain, within the Indian context also, that despite, women spending, having a larger share of household and also, burden of household work and also involved in labor, say outside the home, there is an increase of, they're still, putting on, or still, gaining weight. And part of the reason, and, or experiencing obesity, and part of the reason is that decreasing nutritional diversity. A lot of these women are coming from income insecure families. Okay, we're not talking about the rich and those, and for whom obesity has different reasons and causes, but we're talking about so greater consumption of, say, rice as against other food, items, is also leading to this kind of is leading to this kind of or is contributing to weight gain and obesity, when women, given the hard work that they do, both within the context of the house or in the farm or in agriculture or in any, so this should also lead, this also is an area for further inquiry and research. Now, we will also see that climate change will also, affect women, and women will face the disproportionate impact of climate change. Okay, because climate change is going to have a gender differentiated impact. We'll see it more pronounced among rural women, because rural women rely more on biomass, okay, such as agricultural crops, waste, and food and other forest resources than men for their energy needs and livelihoods. And as all of this, as climate change creates greater vulnerability, okay, you're going to see a reduction of this biomass, and that's going to also lead to greater food and nutrition insecurity. Rural women, as I said, and I'm repeating this again, also depend much more than rural men on ecosystem services for food security, as they are often heavily involved in agricultural production and management of natural resources. So climate change is definitely going to, have a tremendous impact on these ecosystems, and which will have a resultant impact on food security. Now, agriculture in India drives in the economy, but we know that it is heavily impacted and is being heavily impacted by climate change. There are so many environmental and climate uncertainties that are keeping farmers on their toes. And so, you're seeing declining monsoon rainfall, which is also triggering a looming water crisis. And all of this is going to lead to lesser crop intensification, what you say is also going to lead to a food crisis. Okay, there will be lesser crops that one will be able to grow. And this is going to have a major, bearing on, food insecurity and nutritional insecurity. Now, during the agrarian crisis that India was experiencing, also, pushed, farmers in the country to go on that massive protest, okay, which drew a lot of international attention and national attention. So the government was basically unveiling these new farm laws, which triggered waves of protest from the farming community, and women were also a very, very significant part of that farming community. And they were protesting because they felt that the new laws do not, among other things, the corporatization of agriculture, but they also felt that the new laws did not promise a minimum support price for their crops, something that the present laws were doing. And the farmers and organizations working for them, basically stated that a country like India, where more than 50% of the population is directly or indirectly involved in agriculture, a guarantee in the form of minimum support price for their crops is crucial, especially considering environmental and climate uncertainties. And therefore, the government really needs to intervene in relation to the agrarian crisis, because the agrarian crisis is definitely going to cause, if it persists and continues, is going to cause severe food and nutritional insecurity, severe hunger and poverty, and women will also bear will bear a very large share of that burden. Now we also see the urbanization. So that was the rural agricultural context. So you see greater urbanization happening for many reasons, and we won't go into that now. But you see persons from rural areas who are, when they tend to migrate into cities, they are migrating essentially into an economic structure where access to cash alone determines their food security. Okay. And most people who migrate, especially who migrate for various constraints, okay, poverty, agrarian crisis, displacement, eviction, violence, caste-based discrimination, who move for these reasons, are basically coming into cities and are predominantly working in the informal sector, which is characterized by low and uncertain wages, no job security, no, no social security and benefits, okay? And therefore, you see many poor urban households in many developing countries, including, spend more than half of their earnings in food. And so while in cities, food is available year-round, a growing number of urban poor are facing a daily struggle to feed their families. Okay, price fluctuation, sometimes even of staples, which are increasingly being imported from other parts of the world, hit the poor hardest. Okay, and you see illness, a religious ceremony, a family wedding, a COVID, pandemic can deeply cuts into fragile food budgets of the urban poor, paving the way for malnutrition and stunted childhood. And we know that even among the urban poor, it is women and children, young girls, it is Dalit women and, migrant women, it is homeless women and children, it is women in sex work, women in disability, and even say trans women, particularly who are during a crisis, who will be extremely vulnerable to any malnutrition and food insecurity. Okay, and urbanization is also seeing cropland loss, which is also going to lead to greater undernutrition. Now, coming to, so this was the larger context of, gender and nutrition. I just want to talk about certain, programs and by Government of India and certain initiatives. So yes, we have made as a country significant progress towards self-sufficiency in food production. Okay, we have a five-fold increase in food grain production from 15 million tons in 1950-51 to about 250 million tons. We have specific nutrition-specific interventions. You have the integrated child development schemes. You have, which is a pan-India nutritional and child development scheme, and the nationwide midday meal scheme. Okay, you also have the National Food Security Act, which was passed in 2013. And it basically, legally entitles up to 75% of the rural population and 50% of the urban population to receive subsidized food grains under the PDS. And in 2017, Government of India launched the Poshan Abhiyan, which is a flagship national nutrition mission, which aims to improve nutrition amongst children, pregnant women, and lactating mothers. But despite all of these efforts, okay, you still see that significant percentage, and I think India, has the largest proportion of food insecure people in the world. So it's very important that that we understand that, while we've made some progress, or while perhaps we can even say we've made substantive progress, we really have a long way to go, because it's unacceptable that women and children and vulnerable groups, okay, basically, either sleep, go to bed hungry, or experience food and nutritional security. There is a lifetime cost to all of this in terms of health, in terms of education, in terms of the overall economy, and in terms of national well-being also. And we need to address this. This has to become an important political agenda, within this country. And now, added to all of this, you're all, I mean, so, while you have the larger, context of, food and nutrition insecurity, we're also seeing how, a country which is predominantly non-vegetarian, okay, we're also seeing the unpalatable politics of food, and which is just increasing and intensifying. Okay, and is also becoming so targeted, and is actually also taking away, valuable food, intake. I mean, nutrient intake, nutritive intakes for communities who probably also need them the most. So the inclusion of, say, eggs in midday meals is an easy way to meet the nutritional needs of young children who have access to cereal-heavy diets, both at home and in schools. Yet over half the states in the country do not allow the distribution of eggs to school children. Okay, and you're seeing the advancement of a vegetarian ideological narrative, that is happening in the country today, basically disregards. One is it's also violative of fundamental rights, the rights of individuals and community rights to choose and basically to eat the food of their choice. But this kind of vegetarian ideological narrative also disregards India's unresolved malnutrition problem, despite us, as I said, having a huge a huge ICDS and midday meal programs. Okay, a huge ICDS and midday meal programs. Now, then you also have the additional effect of attaching the virtue of purity to vegetarian food, and corruption or unhealthiness to meat and poultry products. Also leading to a kind of stigmatization for those who are handling or involved in such kinds of, either in consumption or in processing or in or economic processes related to meat and poultry products. And the beef ban, okay, as I would just like to quote R. Mohan Raj, the Karnataka state convener of Dalit Sangharsha Samiti, says it is the people from marginalized communities who face the heat of these decisions. One is you're taking away food choices, you're taking away, food, choices that are affordable, protein sources which are affordable to people. And at the same time, you're also keeping them extremely vulnerable to targeted violence, because of these kind, anti-beef politics. And we're also seeing targeted violence and economic boycotts of certain communities, which is also going to, lead to greater economic and thereby food insecurities. So when you say, okay, that Muslim vendors should not be selling this, or we should target Muslim, meat shops or food, sellers, You're also, one is, I mean, definitely it's a communal issue. It's an issue of discrimination and inequality, but you're also contributing to the larger, food insecurity, because as families become vulnerable economically, women will be the ones who will be also the most impacted. Now, I just want to make my, concluding remarks and then go on to the recommendations. So women are significantly affected, as we've seen, okay, and therefore should form an essential part of any intervention designed to address food and nutrition insecurity. Okay, so women, as I said earlier, play a critical role in household and national food security as food producers, household food managers, and consumers. Okay, and therefore should be central to or an essential part of any intervention designed to address food and nutrition insecurity. As mothers and caregivers of children, okay, and women as mothers and caregivers of children, really do everything to ensure, do what is humanly possible. And one also saw this in the pandemic, how women, for those of us who were involved in relief work, saw the desperation, saw, even, the aggression of women in order to be able to find food for their families. Okay. And therefore, women are mothers and caregivers of their children and families, and therefore should also occupy a central place in nutrition policy and intervention. However, we often see that early marriage means that they are not empowered to take decisions about childbirth and care. So also the relationship between early marriage, childbirth, and nutritional and food security is something which is very, very important. Okay, and the increasing price of food has a gendered impact. So as food prices rise, okay, women will cut back their own consumption to preserve the intake of children and men. Okay, they will eat less, they will eat last, they will eat whatever is remaining, or eat only something to fill their stomachs. And therefore, for these reasons, women, okay, first, because they are directly affected. Second thing, as mothers and children, they are mothers and caregivers of children and families, and they should play a central role in nutrition policy and intervention. And sometimes they are unable to do so because early marriage takes away, means that they are not empowered to make decisions about childbirth and care, and also that the increasing price of food has a gendered impact. Now, often what we see is that nutritional interventions, okay, are very biomedical and neoconservative in terms of, in the way they are framed. And often they equate empowerment, okay, with counseling. So you often talk about, you see many of the, even if you look at our own nutritional programs, you hardly see them embedded in a rights discourse. You're hardly looking at food and nutrition as social determinants of health. We tend to view biomedical nutrition interventions as biomedical, and equate empowerment, that you counsel ignorant mothers, okay, to change their behaviors. It's not as if these mothers do not know better. They are often spoiled for choices because of their situations, okay? And you have very, narrowly conceived strategies, okay, which are also very instrumentalist in nature. You want to address, bring down malnutrition, you want to bring down, child mortality. All of these are important goals in themselves. But the entire trust is on maternal responsibility to to address these issues. What about the state's responsibility? What about, in ensuring a diverse range of responses and interventions to improve livelihood security, to improve access to food, to address issues of climate change, to address issues of agrarian crisis, to address caste-based and religion-based discrimination as well as gender-based discrimination, so that it's not just the maternal responsibility. And in talking about biomedical approaches, in counseling approaches, and you have so many, tons and tons of manuals which are created on effective counseling or interpersonal nutrition counseling or nutrition counseling for the first 1,000 days, okay? But all of these, fail to understand or consider the structural underpinnings of urban and rural poverty, the mobility of rural labor, cost of food, absent carers. If women are out in the fields, obviously the girl child is looking after the family, or older or grandmothers are looking after those families, okay? And therefore that itself will have a bearing on food insecurity. A lot of urban malnutrition is also due to the fact that women have to go out to work, families have to survive, and it is so it becomes then women just don't have the time to breastfeed, they don't have the time to cook nutritious meals. Then you have this rampant advertising which promotes products like Maggie or these wafers or chips and this thing, which becomes shortcuts and also creates nutritional insecurity. So discriminatory societal norms and the engagement of women in arduous farm, non-farm and domestic work, okay? Now, when we're talking about poor quality diets, friends, we are basically talking about these poor quality diets reflect societal inequalities and household food insecurity. So we always need to go beyond fortification of food, which is an important, maybe an important strategy. I'm still not, but it's a temporary strategy. But we need to move beyond biomedical approaches to basically address broader livelihood, social protection, and gender frameworks, okay? To address the crisis of hidden hunger among the urban, rural poor, and tribal households. And now I just have a few recommendations. So, and these are, not in any particular order. But one is, we really need to invest in the infrastructure of the ICDS and Anganwadi centers, as well as improve their coverage. So this is something that must be done. And there are some district level interventions which have aimed to address these issues. They need to be documented and of course upscaled. And I just want to give this example of Angul district in Orissa, which has a large geographically isolated tribal population, but they have periodic grievance redressal camps set up in areas far from the Anganwadi centers to provide ICDS services. Okay, so this is very, very important. Okay, so such mechanisms which basically allow for community engagement. So where you can have grievance redressal camps to say what is wrong with, you're not able to access the food at the Anganwadi center. Is there pilferage? Is it poor quality? Is there caste-based discrimination? Is there discrimination based on ethnicity, gender? What are some of the reasons for all of this? Okay, or poor access just because this thing. It's very, very important. There's also a need to address gaps and inefficiencies in the present setup through public awareness. community engagement, and empowerment with a strong gender and social inclusion lens. Okay, it's very, very important that we help communities to realize their rights and their entitlements. It's the right of people to expect food and nutritional security of a certain level. Okay, and then act as a deterrent to inefficiencies and gaps. So how do we also create community-based solutions to malnutrition? And these community-based solutions would not mean taking away the role of the state, absolving the state of its role and its responsibility, but for greater community participation, resilience, the use of community wisdom, the use of community monitoring, and in these kinds of it becomes very, very important. Then we need to have a good targeted public distribution system that takes care of the household needs for staple cereals. And I personally feel that we should also be expanding what is available, different, within the public distribution centers, within the public distribution centers, because it would then, provide some amount of relief. It would allow poorer households to relocate limited incomes towards other essentials. Okay. Now, eggs need to be provided in schools and Anganwadis under the midday meal scales, okay? And the integrated child development schemes, okay, under the midday meal and this thing, are some ways in which the diets of poor women and children can be augmented. Now, we also need to use other rights-based measures, such as the public works program, the Mahatma Gandhi, such as public works program, Mahatma Gandhi National Rural Employment Guarantee Scheme, support livelihoods and incomes, okay, to support livelihoods and incomes, sorry. So, and what studies have shown is that while income from Manrega is linked to increasing household expenditure on milk and meat and fish among poorer rural households, okay? But one has also seen recent incidents of starvation deaths in rural and tribal areas, which have been attributed to poor implementation of the National Food Security Act. So we really have to push for better implementation of the National Food Security Act. We need to also recognize women's participation in agriculture and the negative consequences if their burden increases any further. Because we saw that as women's burden, household burden and work burden increases, her nutrient intake also decreases, because women, basically want to save their energy, okay? And this has a bearing for not just themselves, but also for their children. We need policies to be aligned to women's needs in agriculture, be it technology, finance, and extension. We need women-friendly farm mechanization, as agriculture is facing labor scarcity, and there is a rising trend of feminization of agricultural labor force and work. Okay, so this is very, very important. Then among the other recommendations are that the focus of nutrition programs in India has largely been post-birth, with child and feeding centered interventions, okay? Now we know that 50% of the growth failure that gets accrued by 2 years of age occurs in the womb owing to poor nutrition. It's owing to poor nutrition, of the mother, both during pregnancy and before pregnancy, okay? So we need to basically have a lifespan approach. when we are looking and not just focus on, post, which is important, but post-birth with child and feeding, with, post-birth interventions, which are basically child-centric and feeding-centered interventions. But we need to see how are we overall improving the quality of food security and nutrition security for women, because, the 50% of the growth failure that gets accrued by 2 years of age occurs in the womb owing to poor nutrition. Okay, and we need to also improve women's labor force participation. We've seen that when women participate in paid work, there are better nutrition and health outcomes, okay, for the woman and also for the family, okay, because paid work is essentially driven by greater decision-making power, okay, that emanates from labor force participation. Another major issue which we also need to address is the issue of exclusion, okay, which is one of the major reasons also for rising malnutrition levels across India. And we saw this in very acute ways, even during the COVID pandemic. So we see that migration creates geographical exclusion because a lot of our schemes are state specific. Okay, so when people move from one state to another, they are not able to access schemes. So that if women move from one state to another and she delivers there, she may not be able to avail of, or if she is moves from one state to another, she may not be able to easily access services. Okay, but while migration creates geographical exclusion, bureaucracy and its need for document creates a form of social and economic exclusion. So, which is very, very important. And we've seen how, how this has really impacted the lives of poor and vulnerable communities. So as Sheila Kansori says, she's a social worker, that if the Aadhaar card is not updated or the name of the woman in the bank account is not changed, then from her father to her husband, then despite being in need of nutrition, she is denied government benefits. So these are bureaucratic exclusions that create what you say, severe vulnerability in people. So one is, you see migration that causes geographical inclusion. You move from one state to another, so you're supposed to have one nation, one ration card, but that portability doesn't really work well. So people are not able to access food grains in the states that they have migrated to. Okay? They are not able for many reasons to also access services, whether it is, antenatal care services or other services. And you also see this kind of exclusion that comes from social, bureaucratic, from a certain kind of bureaucratic burden, which creates a form of social and economic exclusion. Now, the Aadhaar, the biometric government ID scheme, is a must-have for accessing nearly every social welfare and program. But, you have a system that was meant to serve the poor more swiftly that has often been accused of failing them, okay? And the poor have complained that linking the ID to their bank account or updating it with new information, such as when they migrate for work, involves multiple trips to government offices, which they cannot afford. So you see different levels, systemic exclusions, okay, by creating a certain kind of a bureaucracy. Now, you also see that the nutrition and its malnutrition and its consequences, can be partly attributed to inadequate political focus on budgetary allocation made to tackle this issue. And there is research that suggests that if you, rupees 75 spent on nutritional interventions in India could actually generate $1 of spent on nutritional interventions could generate about 34.1 to 38.6 in public economic returns. But I mean, and that India loses up to 4% of its gross domestic produce product, sorry, and up to 8% of its productivity due to child malnutrition. Of course, I mean, but still you see that there is inadequate political focus on budgetary allocations. For example, the total allocations for the union budget of 21-22 saw an increase of 14.5%. Okay, but the various nutrition schemes, sorry, but the allocation towards child nutrition dropped by 18.5% compared to 2021. And there are also shortcomings in implementation which need to be tackled. So we cannot just talk about a shortfall in budgetary allocations, okay, for India's malnutrition crisis. There are shortcomings in implementation too. You see, there is there is an underspending of amounts, actually dispersed to state governments. And, for example, of the approximately 4,300 crore released under Poshan Abhiyan from March 2018 to December 2019, only 1,570 crore have been spent. And this is a flagship program. So one doesn't really understand why, and with such severe levels of malnutrition, undernutrition, stunting, wasting, why are these, why is the money not being effectively spent? So what are some of the long-term and, comprehensive strategies that we need to look at? We need to look at maternity entitlements, which should be universal, unconditional, not that if you have 2 children and beyond 2 children, the state will not take care of you, because those families who are having more children, women don't have a choice in that, and they are often the poorest and most vulnerable. Adequate entitlements, wage-linked entitlements, and labor rights, should be seen as a social determinant of health, should be recognized as social determinants of health. We need creches. Care and unpaid care work is an important, as I said, determinant of, nutrition. We need to insist on food as a major determinant. And today, eggs have unfortunately become a symbol of struggle or again, centralizing tendencies. We need to protect and enhance the midday meals, okay? We need to also protect and enhance the ICDS and supplementary nutrition intake, scale up quality, community monitored programs, as I said earlier, kind rather than cash, protect and enhance the PDS, universalization, decentralization, rationalization, including millets, delinking from Aadhaar, very, very important. We need more research on nutrition, food insecurity, food insecurity, nutritional insecurity, and gender and nutrition. And we need to publish more on that. We need policy advocacy. We also need to fight corporatization, centralization, and minimalism. Unfortunately, when it comes to the poor, it's always poor services for the poor. Okay, and also fighting corporatization. So yes, we have rough, but a lot of this will have to be done with evidence. How do you fight off contractors? Okay, and encourage self-help groups in managing food of communities, food for communities. That could be really very important. We need to defend freedom of choice, eggs, non-vegetarianism, beef eating. We need to create an informed mass of affected people. If people are hungry, it's not because of their inadequacy. If people are experiencing food and income security, it's not because of personal inadequacy and insecurity. These are larger issues of justice and rights. Okay, so we need people to start framing the questions from a position of justice and rights. We need to bring food and nutrition insecurity onto the political agenda, and we need to bring in, okay, the judiciary. the National Food Security Act, and as was done in the Supreme Court case of 2000, and the right to food, that was the PUCL case of 2005. So this is basically what I have to say. Yeah.
Thank you, ma'am, for your presentation and illuminating us with your elaborate and in-depth analysis on the topic. Now I would request our convener, Professor Veena Vaswani, to add some comments and give some insights. Over to you, ma'am.
Yeah. Thank you, Brennan, for such wonderful, comprehensive presentation, made yet very simple so that anybody can use it as a small chunk and understand and reflect upon it. Because the complexities could remain complex, but then you have made it with effort to systematically analyze it. It was quite depressing to know that we are adding to the 60 million of hunger at the end of 2030, and especially India has a major role to play in that. So, and you built up the context very well, that 4 out of 10 children who are not reaching the full potential. Now, this especially, it is hurting to know when the food grains rot and rodents eat them and they reach the gutter. But it's somewhere with all our most intellectual infrastructure as well as IT, we are not able to reach it to the place where it is needed at that time. We do believe in covering up the starvation deaths, and sometimes when they're exposed we try to bullshit somebody or blame somebody, because as a forensic person I do remember a couple of cases when we had reported for deaths due to starvation. We were literally reprimanded not to say it is due to starvation. It could be age related or whatever, because then it becomes questionable as to how the starvation took place. But this is if how we are responding, then we will not get the truth out. And not knowing the truth, it is just that you don't accept your ignorance and you're living in a world of fantasy. All is fine. So you brought it out very well. And also the hidden hunger. Many people think having a loads of rice and dal is enough and they've had stomach full. Even to the person who's eating, sometimes you do feel that what he has eaten is not of a nutritional value, but only calorific value. So it has adversely effects. You brought it down, it will malnutrition, micronutrient deficiency, as well as obesity. And also that how the consumption of food has reduced, green vegetables has reduced over a period of time, and the paradox of wanting to do good, National Poshan Abhiyan, but with the kind of playing to the emotions of a particular people for vote banks, that you said no eggs, no meat, no this, no that. So who should be calling the shot? Is it enough for people who are in power to call shots? Or should this be based on evidence that is available scientifically? Because many a times if we do this, then we become just a kind of people playing to sentiments and not to science. And when children and their upbringing is concerned, like you said, a good nutrition food it is not just an option. It's actually immediate, urgent requirement to bring up good citizens. So if we look at that, then somewhere we need to make amends to what we have and reduced it, including the milk for that matter, including the money for Poshan Abhiyan, which doesn't get distributed, where 1 liter of milk gets mixed with 100 liters or bucket of milk to be given to people. So somewhere there is an effort which requires to be put in, and you brought about the corporatization of agriculture as well, and especially when family moves to cities. The plight is quite bad because it is not just the cash that matters, but they need to dole out cash for every other thing, thereby the food gets compromised. You brought out very well even the ICDS, what were the issues with that, and the national food security, including the social inequities of today with all this. And you especially stressed upon the fact that food insecurity leads to overall insecurity of the woman from the development stage to gestation, I mean, as well as the delivery, and how it impacts the newborn as well. So lastly, the engagement of the community, which is very important because many a times community is happy with a knee-jerk reaction by the policymakers. But that doesn't meaningfully translate into a nutrition for the people of that community. And especially when you talked about $1 or what it requires in the nutrition, if it is deprived, it amounts to nearly, I mean, it could accrue about $37, which is not happening. So I think you have made it a very good case for reflection of the policy makers, how best we can uphold the values we stand for in gender, which is not just gender, but with a good nutrition, it can literally flourish well. So very beautifully brought out points. Thank you, Brennan, for that.
Thank you, ma'am. Vibhuti, ma'am, would you like to add some comments, or shall we go to the question and answer box? Ma'am, please unmute.
She has made, Professor Brinal has made a very powerful presentation showing interconnections of food and nutrition security with the larger global political economy and also the macro reality of climate change. I think really enlightening lecture because with the eye-opening data-driven analysis, which showed importance of addressing inequality in access to food sovereignty by the nation states in southern part of the globe, and also the important role, crucial role that rural women play in both in the household and national food security, I think was convincingly analyzed. And I think most important aspect of recent that deconstruction of farm laws, how they are accentuating hardship of women farmers is very illuminating. And I really liked her critique of biomedical and non-conservative, neo-conservative discourse on quote unquote ignorant mother, and focusing the importance of determinants of hidden hunger, such as structural underpinnings of rural and urban poverty, and the need for community engagement and evidence-based poverty recommendation. I think that is the USP of Professor Brenner's lecture. Congratulations, and it was a really very, very illuminating experience. Yeah.
Thank you so much, ma'am. Now we will move on to the question and answer box. The first question is by Sagar Shindeji. The question is, with the growth in the microfinance industry and the claims of the financial inclusion, has this impacted positively the nutrition issue resulting outing of gender?
I'm just reading the question. Okay. See, just a moment. And I just looking at the growth of the microfinance industry and the claims of financial inclusion. Has this impacted positively? See, I would, I have not really studied this area, okay, of microfinance and what you say, and how is it basically affecting inclusion. But to think that, I have always, when women are, how many of these microfinance schemes are actually accessed by women? That's my first, many of them do not get access, okay, to microfinance schemes. Then even when women take, finance, it's often for the household. It is to often tide over an emergency of the household, for a household need or to support our household, and often maybe, for an illness, for a daughter's wedding or a son's education, or to support the spouse. So whether she is directly, being benefited by this thing, I think from what superficially I have read, it has really not made much material difference to her life. Okay, that microfinance is really, may have, contributed to some levels of, say, security in terms of being able to access finance easily if you are able to get it. But it doesn't really make any huge qualitative difference in one's life. So how much of that money is going into, what you say, better nutrition, better health outcomes, better access to healthcare for herself. And sometimes what we've seen, because even when we're talking about supplementary nutrition, your women are given eggs or they're given supplementary nutrition at the centers they go to. When they take it home, they take it and go home. It is then given to everybody in the family. So women do not think from their standpoint only, you know, and they will prioritize and they will privilege other issues of the family, other members of the household. So from my, you know, broad reading of this, and you know, I mean, this is what I have to say. Maybe Vibhuti, who's an economist,
I think I would like to
add.
supplement that. You are right, because all the studies on microfinance have shown that women are buying. Basically, it is for education and health. Paying for children, because now there's a privatization of education and the quality of the public education is so low that even poor people, they are now sending the children to this thing. And health emergency, major reason is health emergency. And women, as you said, they eat last least and leftover. So even when they were even if they are members of microfinance, that cultural gender norm, no, that doesn't change.
Yeah, and they may often borrow for others, no? So they may not even have control.
For the family, even ILO study has shown 2/3 of the earnings of women directly go for the emergency needs of the household, not their personal. So men use it for their smoking and BD and going to movie, and all. Women don't do that.
Yeah.
Ma'am, the next question is by Susrita Ji. She's asking, programs like AMB, which provides IFA tablets to adolescent girls, but not boys. What should professionals working with adolescents do to advocate for inclusion of boys to make these programs more gender sensitive?
Yeah, so I think, you know, when we're talking about, you know, in being inclusive, we don't mean you neglect anyone. Okay, so remember, as women, as feminists, we want a just world for everyone. And every human person needs to, you know, be in an environment where she, he, they, them can thrive. Okay, and you know, have the fullest of opportunities. So definitely when we are talking about women and girls, we are saying, okay, you know, women and girls, because of, and you've had enough of inputs and all of that, okay, do face, you know, what you say, discrimination, and because of that discrimination, lose out on many fronts. Okay, but that doesn't mean, so I mean, in any program, we have to ensure that everyone is getting access, and then the more vulnerable groups, okay, like women, girls, you know, Dalit, you know, women, girls, Adivasi women, girls, Muslim women, girls, women and girls, you know, with disabilities, all of them have access to services. Okay, but you may also be in a situation where, say, an adolescent boy is being, you know, from a Dalit community, is facing greater discrimination than a girl from an upper caste community. So it is your responsibility to ensure that just because you're working, you know, on women's issues and gender issues doesn't mean you neglect that boy. You have to see how marginalization is actually playing out. And as health activists, as gender activists, we are concerned about marginalization of all peoples.
Ma'am, last question is by Dr. Rath. Dr. Rath is asking, can you please recommend measures for vegetarian fight against hidden hunger?
I'm sorry, but I am not a vegetarian specialist. But, you know, I would basically see, but on a very basic level, say that if you're having, you know, a diet which is diverse, you know, which has all the elements of food in it, okay, I think you should be good. So I am not making a case for vegetarianism or non-vegetarianism. I mean, people have a right to choose, and that choice could be the choice of vegetarianism. I think what we should aim is to see that we're having proper balanced diets. And, you know, and for that, we need to know why people are not having proper balanced diets. You know, having a balanced diet is, you know, and today you see so much of healthy lifestyle and, you know, programs. The moment you look at your mobile phone, you know, you have all these different weight loss programs or healthy diet programs, they do cost money. And as I would really, want to reiterate this point, which I made earlier, that dietary inadequacies basically are a reflection of widespread deficit in achieving a host of social and economic rights. It's not that people want to eat only rice and dal. Okay, it's that they cannot afford to eat other things. So I would say in terms of the specifics of a vegetarian diet, I will not be able to go into that, but I would say that having a balanced nutritional diet which can be easily accessible, encouraging families to, for example, and communities to eat what can be locally grown. Having community kitchens will all go in, kitchen gardens. And we've seen these experiments, with certain, some of our students was placed with an organization in Orissa, which was working in a district with severe malnourishment and malnutrition, sorry. And they started, and it was a tribal community. They started these kitchen gardens, and over low-cost kitchen gardens, and over a year, after some years, they saw that these families were, or these communities were able to grow almost, about 6 to 7 varieties of vegetables and leafy plants, and were able to consume them. So they were using their own land and the local resources, and with some amount of advice and guidance, they were able to grow diverse crops, which were and were able to have more diverse diets. Yeah.
Thank you, ma'am, for such a lively deliberations. And with this, we come to an end to our day 2 session. Now, I would like to call upon Professor Veena Vaswani to conclude our second day and share some words.
So the second day again turned out to be very educative, like the first, very interesting in the fact that the flow, it literally flew from one to another without any discontinuity. So when Dr. Amar talked about the ethics of assisted reproductive technology, and he brought in properly the different positions of the fetus, including the legal things as in question, what are the weaknesses with these regulations, how it can be strengthened, and then that was regarding the reproductive technologies. And then we moved on to the second part of the discussion. And which was the second part? Can somebody help me with that?
First one was Ketki Ranade.
Ketki Ranade. Yeah. So I think we started with Ketki Ranade, sir.
On gender diversity, very
gender diversity, and how the otherism is making a whole schism between the normal and the not so normal, and trying to continuously have a particularly looking down at a community and stigmatization. So she brought in those concepts very well, and later on Amar continued with the reproductive technology, surrogacy, the issues, the problems, the challenges faced by them. And then the third part of this discussion with Brynel, we really didn't know today when the time passed, and I was just looking at it, and now I say, it's my goodness. So this was again when Brynel brought in about the gender, the multisectoral way in which the gender is affected. Excuse me, sorry. So, and also how the gender, the nutrition, and how it can affect in such consequences which are generally not understood. So, but in a critical way of how it impacts, including the unborn child, and how it can be benefited by improving the nutrition, and to the policyholders, especially when it came to deciding how in the school food, the Anganwadis, the schemes, Poshan Abhiyan, the things have to be made better. So this was a part of today's discussion. I straight away found it a vertical learning curve for me. Thank you very much for the presentation, both the Vibhuti ma'am.
Yeah, and I think I would just like to read Dr. Meenakshi Gopinath, who has beautifully summed up. I think that can be applied to all the 3 sessions and the whole day. That thank you for looking so lucidly at the multidimensionality of structural inequalities and EEE disadvantage. I think this is true for all three lectures. The multiple vulnerabilities and intersectional vulnerabilities of transgender population, LGBTQIA population, then and as Ketki said that, okay, they are there, but it is not add and stir approach we need to have. We need to completely stir our whole understanding and the stereotypes, prejudices, stigmas, and exclusion. That is one. And even same thing came out in Amar's, this thing, the inequality of those who are assigning the task to surrogates, and the role of pharma industry, role of private sector, and also who is vulnerable, and deconstruction of series of laws and GRs that we have. And I think Brennell's was extremely important in terms of the global political economy, that she tried to interconnect, show the interconnection between people's vulnerabilities, big pandemic like of disaster, health disaster, role of the public sector, and also the nutrition standards of the people, and the government programs most important, and that too in the context of more and more sectarian forces which are also intervening in people's food habits and also violation of human rights that is highlighted. So it became a very all-encompassing holistic understanding of the issue, though the entry points were gender diversity or assisted reproduction or nutrition, but it connected it so well with the larger macro reality.
Thank you, Professor Patel. Thank you, Professor Vaswani. Now, as we come to end of day 2 of an immersive online certificate training course on perspectives on gender through healthcare lens, I, Sauravi Ghimire, researcher at IMPRI, Impact and Policy Research Institute, would like to propose the formal vote of thanks on behalf of Center for Ethics, Yenepoya, and IMPRI, Gender Impact Studies Center. We are grateful to Professor Vibhuti Patel and Professor Veena Vaswani for steering the session, and our eminent expert trainers, Ms. Brunel D'Souza, Dr. Ketki Ranade, and Dr. Amar Jesani for their insightful sessions. We thank all of our participants who have raised pertinent questions and actively involved in today's deliberation. We welcome you next Saturday on June 18th for our day 3 session of this excellent training course by distinguished experts, Dr. Aparna Joshi, Ms. Renu Khanna, and Professor Anita Ghai. We hope you continue to join in future to our IMPRI Web Policy Talk and Web Policy Learning. Wishing you a good evening, and thank you.